Good afternoon, friends. I welcome you all. I am Dr. Rasik Shah, pediatric surgeon at SRCC NH Children's Hospital, Mumbai. Today's masterclass, we are planning to discuss about hepatoblastoma. As most of you know that at SRCC Children's Hospital, under one roof, we do all kind of management, which includes bone marrow transplant, solid organ transplant, neurosurgery, cardiac surgery, laparoscopy surgery, and all kind of medical management. We have very good PICU blood bank anesthesia team to help us. Today's masterclass is devoted to hepatoblastoma. We have a very large team of oncologists and oncosurgeon with us. So we intend to start in a couple of minutes, and our first speaker was overview of hepatic tumors by Dr. Purna Kurkure. She will not be able to join because of Ganesh program at her home, but Dr. Chintan Vyas and Dr. Kriti will take care of the first talk. The second presentation is by Dr. Kriti on clinical presentation of hepatoblastoma. Then Dr. Sonal Garg will tell us about imaging studies in hepatoblastoma. Dr. Shefali Jadhav will tell us about pathophysiology of hepatoblastoma. Then Dr. Ruchira Mishra will tell us about chemotherapy for standard risk, and then high risk by Dr. Chintan Vyas. Surgery for hepatoblastoma, I will take care of the principles, and Dr. Ashok Thorat will tell us more about liver transplant for hepatoblastoma. And last is our junior consultant in pediatric surgery, Dr. Manika Boypai. She will tell about radiation therapy, role of radiation therapy in hepatoblastoma. So once again, I welcome you all, and I'm very happy to know that a lot of people have joined even online, and in one of the auditorium in Chennai, they are going to have live relay of the same program. Once again, thank you all, and I will invite Dr. Chintan Vyas to give overview of hepatic tumors. And Dr. Chintan Vyas is hemato-oncologist with us, and he is good like all others in management of solid tumors as well as bone marrow transplant for ALL. And overall, we have done more than 150 bone marrow transplants. And Chintan, overview, you want to start? Yeah. Okay. ये लैपटॉप किसका है? इसमें ईमेल ओपन होगा क्या? आमाचे करा
आपण आमाचे माइक्रोसॉफ्ट मुझे ईमेल
क्रोम में तो
अच्छा तो मैं अपने ईमेल गूगल जीमेल
So we'll start in a minute with the overview of hepatic tumors. स्क्रीन शेयर करनी पड़ेगी।
Put the screens.
Thank you very much, sir, for a very kind introduction and always inspiring to take this solid tumors to all to discuss between us, and also to share our views to pediatricians, to general practitioners. Although the solid tumors in children, as many of us has told in the previous seminars, it's very rare, but it's very peculiar, and we have to manage in a multidisciplinary team with a lot of discussions with our other colleagues in the lab, radiology, as well as the pathology, and amongst us also. And the same holds true for the liver tumors in children. And we always know that the liver tumor in children, we usually don't hear of commonly. We always hear that the adult tumor related to liver. But in the pediatric, particularly the one who are dealing with the children, they do sometimes see maybe once in a year or once in 2-3 years these type of problems. The one I'm talking about, a general pediatric level. When they will see these type of patients, particularly with some abdominal mass in the liver, and at that time we need to know that what exactly we need to do at the ground level when we first see the patient, and then we can refer the patient to the higher center for further management. So just maybe 10, 12 slides on the overview of children I will tell, and then we'll discuss the commonest malignancy in very much detail. So as I've told, the liver tumor in children is extremely rare. It is so rare that there are only 1.5 cases per million in less than 18-year of age group. 2/3 of the liver tumors are malignant, and out of these 2/3 malignant tumors, 2/3 is hepatoblastoma. So almost majority of the chunk of the liver tumor in children is occupied by this one of the malignancy, which is called hepatoblastoma. And most common malignant neoplasm of the liver, particularly, is metastatic lesions. Now, hepatoblastoma is a primary hepatic tumor, right? And sometimes we get a distant metastasis also from the solid tumors of other organs in the liver. Third most common abdominal malignancy in the children, and we have discussed the previous two in our previous two seminars. One was Wilms tumor and one was neuroblastoma. So now we are on the third commonest malignancy as far as the abdomen is concerned. Now, whenever we see the liver tumor, we always wanted to see whether these tumors are always a malignant tumor, or there are some sort of benign lesions or benign mass also there in this age group. Now, what could be the benign lesions in this age group? So one, the commonest is epithelial, like focal nodular hyperplasia, or hepatocellular adenoma, like common adenoma. Then second could be a mesenchymal tumors, and these mesenchymal tumors can be a hematoma, mesenchymal or cavernous hematoma, or hemangioendothelioma. And the third is teratoma, inflammatory pseudotumor, and neoplastic cyst. Now, when we talk about these benign tumors, we need to understand that the clinical presentation may be sometimes misleading, and we cannot 100% be very sure that what mass which we are feeling as a clinically in our OPD may turn out to be a malignant or benign. So it is always better to go through a detailed analysis of those benign mass. There is not very much age-wise distribution also has been described with this benign masses. So it can be as common as hepatoblastoma also. But in general, if we are thinking that the liver tumor, as I've told you, the common is not the non-malignant mass, but the malignant mass. But 1/3 of the cases do comprise of these non-malignant masses. What are the malignant masses, malignant tumors? They are hepatoblastoma, hepatocellular carcinoma, hepatic sarcomas, and metastatic lesions. Hepatoblastoma, as I've told you, is the commonest, which we'll discuss in very much detail in next 2 hours. Hepatocellular carcinoma is a tumor of adult, which we always hear, but it is not uncommon to have hepatocellular carcinoma in children, particularly those who are beyond 2 years of age or maybe beyond 5 years of age. Now, usually the hepatoblastoma is a tumor of young children, particularly infancy or up to 2 years. But sometimes you get hepatoblastoma or hepatic mass at the age of 5 years, 6 years, 7 years, 10 years, 15 years. Now, in those age range, the hepatoblastoma is not that very common. And in that case, in particular, those age who are little older children or adolescents, we need to be very careful that are we dealing with only hepatoblastoma, or we are dealing with hepatocellular carcinoma, or we are dealing with sarcomas. Sarcomas also not very unusual to have, particularly when your child is maybe 10 years or 12 years of age. So age does plays a role, particularly when we are dealing with malignant mass. And metastatic lesions, let's say if we have a liver, if we have a Wilms tumor, it can go up to liver. If we have a neuroblastoma, it can go to liver. So these are the solid tumors, sometimes do metastasize to liver, apart from the primary liver malignancy. 5 primary lesions that occur only in children, and this is very important: infantile hepatic hemangioendothelioma, hepatoblastoma, mesenchymal hematoma, rhabdomyosarcoma of the biliary tract, and undifferentiated embryonal sarcoma. So if these are the different pathology altogether, which our pathology colleague will also tell us in detail, but the commonest will be these 5. So you let us see if somebody wants to evaluate in an OPD basis that what could be the differential diagnosis of my hepatic mass in these children. These 5 things should come into their mind, and then we go up to the investigation modality and to prove whether it is out of these 5, which one is fitting most. As I have told you, age less than 5 years, hepatoblastoma and infantile hemangioendothelioma is the commonest. And as I've told you, more than 5 years, hepatocellular carcinoma, and as we see in adult, focal nodular hypoplasia of the liver is common. Epidemiology, this is a very common question asked multiply in our OPD, as well as we discussed that what is leading to these tumors. Are they only genetic, or there is some acquired factors in this? So androgen therapy for aplastic anemia, although androgen therapy for aplastic anemia is not very commonly used nowadays, most of the people go for a definitive treatment. But if you talk about previous years, maybe 20 years before, a lot of aplastic anemia, which is also one of the common hematological conditions in children, have been used with danazol. And these type of treatment sometimes can lead to hepatoblastoma, hepatocellular carcinoma. Some of our drugs also, now newer drugs also, can lead to liver fibrosis and all those things. But yes, androgen therapy needs to be considered as one of the risk factors. Chronic iron overload in beta thalassemia. Now, chronic iron overload in beta thalassemia does not lead to a primary hepatic tumor, but it leads to a hepatocellular carcinoma. Now, what is hepatocellular carcinoma pathogenesis in this type of patient? It is predominantly chronic hepatitis B and C, particularly chronic hepatitis C infections. And these are the patients who do develop hepatocellular carcinoma down the line, maybe after 15 years or 20 years. We have seen as early as 12 years, 13 years, developing hepatocellular carcinoma in a thalassaemic child. Corticosteroids after renal transplantation, very unusual, but it can lead to sometimes. Oral contraceptives also, it doesn't apply to our patient population, but these are one of the risk factors for hepatocellular adenoma or carcinoma. Patients with type 1 glycogen storage disease has increased risk of hepatocellular adenoma and focal nodular hypoplasia. Liver hematomas may occur in children with other hematoma leading conditions like tuberous sclerosis. Hepatocellular carcinoma, as I have mentioned, liver disease like chronic hepatitis and cirrhosis can be one of the risk factors. Now, when we deal with any genetic disorders, like any tumors in infantile age, we always look for the genetic syndromes behind those tumors. And the commonest genetic syndromes associated with the commonest hepatic malignancy, which is hepatoblastoma, is trisomies, right? Trisomy 2, A20, those kind of chromosomal abnormalities, translocation of 1,4 and rearrangements. Hepatocellular carcinoma and other malignancies are also associated with genetic abnormalities, but sometimes if you have these type of facilities available where you can do the genetic analysis, or if the patient is having syndromes, you must look at the germline mutation, which I mentioned in the second part of the table, which is molecular mutation analysis, to look for a germline mutation which may have led to these type of situation. Usually we do not do in all of the patients, but yes, in syndromic patients we should do. So I will just quickly go to the clinical features. The clinical features are abdominal mass, which is the most common, abdominal distension, anorexia, weight loss, pain, nausea, fatigue, and constipation. These are one of the constitutional symptoms which we see in the babies, which they do not manifest or do not tell always. We need to find out what they are dealing with. We need to take a close history from the parents. Jaundice may or may not always be seen. Weight loss, uncommon except infantile hepatic hemangioendothelioma, IHH, and congestive heart failure and thrombocytopenia, particularly if they are associated with some of the syndromes like Kasavich-Marit associated with hemangioma. Cutaneous hemangioma seen in about half of the patients with IHH, which is infantile hepatic hemangioendothelioma. Rapid liver enlargement, CHF without thrombocytopenia can be seen with liver, AV malformation, and mesenchymal hematoma. Fetal hydrops has been identified by prenatal USG in some of the fetus with IHH and mesenchymal hematoma. So these are some genetic benign lesions which can be identified antenatally also. Diagnostic tests, we do blood test, liver function test, coagulation profile, AFP levels for the hepatoblastoma. Thrombocytosis can be seen in hepatoblastoma in maybe 2/3 of the patients, and anemia with liver enzymes elevation. So we will not go into the detail of these investigations, and we will discuss further in our subsequent talks. But just one slide on alpha fetoprotein, and it is very interesting tumor marker. When we know that alpha fetoprotein is definitely elevated in hepatoblastoma and other germ cell tumors, but it is not very sometimes it gets confusing results. It is elevated in 90% of the hepatoblastoma, but is not elevated in 10% of the hepatoblastoma. And then you do not rule out hepatoblastoma only because your AFP is not elevated. Second thing, AFP is an age-specific marker. So at every month, the AFP values are different from birth up to 2 years. Usually by 2 years or 1 year, 1.5 year, they attain the AFP level as per the adult. Falsely elevated AFP can be seen in hepatitis, cirrhosis, germ cell tumor, gallbladder carcinoma. So these are very important where you will get the falsely elevated AFP levels. Normal AFP levels, as I have described, can be seen in 10% of the hepatoblastoma, and also can be seen in non-malignant tumors like immature hepatoblastoma or fibrolamellar variant of SCC. These are the malignant type of lesions where you do not see AFP rise, and definitely in non-malignant cases you do not see AFP rise. Monitor chemotherapeutic efficacy and detect the disease recurrence. That is another important thing to look after when we are dealing with AFP monitoring. I would not go in the imaging because we have a great radiologist sitting here, so he'll describe the imaging findings. But just what imaging you will do, the baseline ultrasound. In that, what we will see, our radiologist will let you know. But baseline ultrasound is very important to know the organ of origin and to see how is the tumor looking like. CT scan and MRI may or may not required. CT scan definitely should be required, but in which case MRI will be required. So ultrasound definitely in all cases. CT, majority of the cases. When we do CT versus MRI, that our radiologist will discuss in detail. So this is a broad overview of liver tumors. I'll leave here, and I'm happy to answer any questions till now. So if there are no more any questions, yeah. Yes. Yeah, it behaves more like an adult tumor. Fibro, yeah.
So be able to repeat the question.
Right. Right. So the question is about the fibrolamellar variant of the hepatic tumors. Usually they are like either they are adenomas or something like that. So usually the fibrolamellar variant, what we seen in adults, right, is something which is totally different. They are not so aggressive tumors. They don't have AFP rise, as you have rightly said. But in pediatric age population, the fibrolamellar variant is extremely rare. In hepatoblastoma, I have never seen a fibrolamellar variant. In hepatocellular carcinoma, when we talk about hepatocellular carcinoma, also the chances of fibrolamellar variant is very less. So fibrolamellar variant or focal nodular hyperplasia, these are the terminologies which usually is commonly seen in adults. FNH and estrogen. So oral contraceptive is definitely one of the risk factor, and it has been very commonly studied in adult population because the association.
The female developed their vaginal adenocarcinoma. Female baby developed their vaginal. So there was a research or something.
Yeah.
So there's a relation taking estrogen.
So yeah, so mother taking the estrogen supplement, oral contraceptives, do have these type of tumors, but it is again extremely rare. Usually, what mothers take, and usually what happens, the direct correlation is in the patient itself. Like let's say if one person is on androgen or one person is on estrogen or oral contraceptive, those patients are more likely to develop the like adolescent or adult age group, more likely to develop the fibrolamellar variant or like that. To happen that in an offspring is extremely rare, but yes, it can happen. And there is no correlation where we can say that AFP levels can define these things, like how much AFP elevation will tell you that whether it is a fibrolamellar variant or it's a non-malignant tumor, like that. So it is extremely difficult, but yes, it can happen. But the more correlation is in the patient who are taking all those drugs rather than having in offsprings. Okay, so we'll move to our next lecture. The next lecture is by Dr. Preeti. So she's also one of our consultant in pediatric oncology at SRCC hospital. And I hand over to you, Preeti. You can introduce your topic. Thank you very much.
इसके बीच में ही रहना है तो
Good afternoon, everyone. Thank you, Chintan, for setting up the stage, and happy Ganesh Chaturthi to everyone. Thank you, sir, for organizing this and discussing this topic. Couldn't have come at a better time. September is the month where we actually celebrate childhood cancer awareness, so this is just apt. I would be talking about the clinical features of hepatoblastoma. There will be a lot of overlap between what Chintan spoke and what I'm going to be talking. And if there are any questions, either we could take it at the end of the topic in the interest of time, or probably at the end of the presentation. We can see how that goes. So as we've heard, hepatoblastomas are one of the most common malignant liver tumors in children, and the incidence is about 200 to 250 cases per year. This is, of course, the North American figures. There have been significant treatment changes that have occurred in the last 25 years that have led to an improved outcome. In the 1970s and 80s, we would give an outcome of about 25 to 30%. And at present day, with everything that we know about these tumors, the outcome is as good as 80 to 90%. Presentation-wise, it is along the spectrum. These children can present as an asymptomatic abdominal mass. Some children might present as an acute abdomen due to tumor rupture. Some come with the compression symptoms because of the size of this mass. And rarely, there is another presentation where the child may come with precocious puberty as a result of a paraneoplastic syndrome, but this is extremely rare. Differential diagnosis. Now, hepatoblastoma is the commonest liver malignancy in children. Now, other than that, we have hepatocellular carcinoma. And as we've heard, this tends to occur in an older child. Then you have other sarcomas like the undifferentiated embryonal sarcomas, which is the third most common hepatic malignancy in children. Again, the age group here is between 5 to 10 years. These are mainly mesenchymal in appearance if you were to see them under the microscope. The other sarcomas, angiosarcomas of the liver, which have an aggressive subtype, and they do extremely poorly. Embryonal rhabdomyosarcomas, which we tend to see in our extremities. Liver is also another organ where you might see RMS, and this would generally be along the biliary tract. And these children generally present with obstructive symptoms such as high conjugated bilirubin. And the treatment of this is basically along the RMS lines, how we would treat other rhabdomyosarcomas. The other malignancies that we see in children could also be when liver is not the primary, but it is a secondary metastatic involvement of the liver. And the most common malignancy that does that is neuroblastoma in children. So basically when we say stage 4, 4S of neuroblastoma. The other benign liver tumors that we think about when you see hepatomegaly in children, which accounts for about 30% of liver tumors. And as we've heard, hemangioendothelioma comes right on top. And hemangioendothelioma, what you would see is these children present early in life. There is a period of rapid growth and then they spontaneously involute. Sometimes you do need to treat these tumors. They are mainly benign, but it is rarely you would even see metastatic involvement. Then the triad of hemangioendothelioma would be hepatomegaly, heart failure, and anemia. When you see hemangioendothelioma along with consumptive features where you're not able to keep up with the platelets, there is coagulopathy. This is a syndrome that is called as Kasbach-Merit syndrome. The other benign tumors are mesenchymal hematomas and AV malformations. Now, if we were to put all of these down on papers, hepatoblastoma is the most common, which accounts for about 43%, followed by hepatocellular carcinomas, and then you have all of your benign vascular tumors. Mesenchymal tumors, mesenchymal hematomas, sarcomas, all of this account for about 6% of hepatic tumors in children. And then you have the FNH adenomas and other sort of secondary involvement of the liver. As an approach, I think this table sort of simplifies things. And as per, as pediatricians, we tend to group all of them into age-wise, so it makes your life easy. So if you have a child where you're suspecting a liver tumor, and if the age is between 0 to 1, under the benign, you would think of hemangioendothelioma or mesenchymal hematomas and rarely teratomas. If you're thinking malignant, then we think about hepatoblastomas. It comes right on top. And rarely you would think of sarcomas or rhabdoid tumors, yolk sac tumors, LCH, disseminated neuroblastomas, and of course, we should not forget leukemias. In the early childhood, that is between 1 to 3 years of age, benign tumors like hemangioendothelioma, mesenchymal hematomas also come in this age group. The other tumor that also comes is inflammatory myofibroblastic tumors. Under the malignant, hepatoblastomas are still common in this age group, followed by rhabdomyosarcomas. Later in childhood, between 3 to 10 years of age, we think of angiomyolipomas, and in the malignant group, you have angiosarcomas, hepatocellular carcinomas, and other undifferentiated sarcomas. In the older children, adenomas and FNH, all of that becomes slightly common. And in the malignant, again, we would think of hepatocellular carcinomas, lymphomas, and leiomyosarcomas. Now, certain diagnostic clues, when you try to put your clinical features, your labs, all of these things together, might point you towards your diagnosis. So hepatoblastomas, generally, these children tend to have higher platelet count, higher AFP. Children with HCC would generally have an underlying history of being positive for either hepatitis C or hepatitis B. If you are thinking of metabolic disorders, they would obviously have metabolic derangements, and the most common would be hypoglycemias. With biliary atresias, you would have conjugated hyperbilirubinemia. For 4S and stage M neuroblastoma, these children are very, very sick. These are rapidly growing tumors, very aggressive. And you would generally have features of their primary as well. If it's sitting in the adrenal gland, they would come with hypertension and so on and so forth, or really painful bones. Hepatitis would generally have an antecedent history of fevers and purpura. Now, coming to risk factors, we generally tend to get asked this question by parents. When you diagnose a child with cancer, why did this happen? So more often than not, we do not have answer to this question, but in hepatoblastomas, we know that there are some risk factors. And the commonest risk factor of hepatoblastoma is actually prematurity. And especially low birth weight babies and VLBW babies tend to have a higher incidence of developing hepatoblastomas. What you see on the right was a COG study that was done in a case controlled fashion where they've studied 113 children with hepatoblastomas. And they've seen a 50-fold rise in the incidence of hepatoblastomas in children who were VLBW as opposed to AGA babies. The other risk factors are genetic syndromes, which I'll allude to in the next few slides. And there's also this link of certain environmental toxins like heavy metals and also paternal smoking that is related to developing hepatoblastomas in children. Now, why do these VLBW or LBW babies get hepatoblastoma? There are quite a few hypotheses, of which one of the factor was considered to be iatrogenic. As these babies, it's not related to their weight so much as the kind of treatment that they get when they're in the NICUs. So if they're receiving oxygen for a prolonged period of time due to oxygen-free radical damage, or also there has been a link of TPN and then developing hepatoblastomas. And this could also be because, when you give TPN to babies, they're given with this particular tubing, which has plasticizer diethyl hexaphthalate, which is actually a rodent hepatocarcinogen. So it sort of leaches out of this TPN tubing into your system. And all of this is just hypothesis. It's not proven, but it could be causing hepatoblastoma. Then there are certain perinatal factors like maternal hypertension, preeclampsia, increased BMI in the mother, polyhydramnios, gestational diabetes mellitus, and history of infertility treatment. Now, what are the commonest genetic syndromes that we see along with hepatoblastoma? So if you have a child with Beckwith-Wiedemann, that is the most common genetic abnormality that you see. They have to be under surveillance for later on developing hepatoblastomas in their life. The other genetic predisposition syndromes are familial FAP, so that is your familial adenomatous polyposis. And then you have Lee-Fromeny, which anyways is not just hepatoblastomas, but all the other sort of cancers like leukemias and brain tumors as well. Trisomy 8, a lot of chromosomal aberrations that Chintan has spoken about also can cause hepatoblastomas. The other metabolic derangements like glycogen storage diseases, tyrosinemia, Alagille, actually is linked to hepatocellular carcinoma as opposed to hepatoblastomas. Now, what do we do when we are suspecting a lymphoma? So if a child walks in after a good history and examination, it is important to delineate where is this mass coming from. And to help us with that, you do ask for some imaging. So you do ask for an abdominal ultrasound. That is the easiest imaging modality to then sort of see what is the organ of origin. Once we've done that, we look at it closely, and then we are able to get some clues, which Dr. Sonal will talk about, and then decide about doing a CT scan of the abdomen. And if we are thinking about malignancy, then it is always good to also look at the chest to look for metastasis, as hepatoblastomas tend to metastasize to the lungs as opposed to any other distant organs. In terms of getting blood examination, so CBC, doing your basic biochemistry examination would be a must, but also asking for serum tumor markers like AFP and beta HCG becomes important, and it can actually help with clinching your diagnosis. And as we've discussed in your examination, if you're seeing features of Beckwith-Wiedemann, then again, it points towards hepatoblastoma. Getting this history, if they were in the NICU for really long, if they were VLBW, all of this makes the diagnosis of hepatoblastoma that much more common. Now, AFP and beta HCG both are tumor markers, and about 90% of hepatoblastomas would have a high AFP. And they may also be elevated in other tumors like germ cell tumors and hepatocellular carcinomas, and they return to normal with effective therapy. Now, the half-life of AFP is 7 days. This is important to know because when you start treatment, you expect the AFP to fall down based on its half-life. Or if you've done the surgery, you've gone and you've operated, you've brought this mass out, then you have to give it about 5 to 7 days for the AFP to then start falling down, as the half-life is about 4 to 10 days, an average of 7 days. Now, as Chintan has already spoken about, AFP is related to age. So it's important to always look at normograms. You don't see, AFP is not an investigation that you do at one time point. You do it and you follow it up. And it's also important to see where is it lying on the normogram? How high is it? Beta HCG is also something we always ask for, and it is commonly expressed by other liver tumors. And this is the tumor marker that actually causes the paraneoplastic syndrome and then precocious puberty. Now, for any treatment of cancers, now there are cooperative groups which do a lot of studies, which do a lot of trials, and then this whole treatment plan is made. So for the hepatoblastoma as well, we have the European group and we have the American group. The European group is called the SIOPEL and the North American group is the COG. Now, as with other solid tumors that we've discussed previously, like for Wilms, the European philosophy of treatment is always reduce the bulk of the tumor by giving some neoadjuvant chemotherapy, then go in and operate. Whereas the Americans believe in taking the tumor out and then giving adjuvant chemotherapy. So it's similar for hepatoblastomas as well. Now, before going on to sort of staging and risk stratification, it is important to know the anatomy of the liver. So I'm no surgeon to explain it interestingly to you guys, but I think it's quite obvious from the picture. So Quinault was a French anatomist who has described the liver segments, and he's done this on the basis of how the portal vein bifurcates. Right? So we have the portal vein. When it bifurcates and it goes on to the right, it divides so it's anterior and posterior. Posterior to that is your segment 1, and anterior to that is all the other segments. On the left, you have your 5, 6, 7, 8, and on the right, you have your 2, 3, and 4. Now, in between these segments, you have the hepatic vein. So the right sort of differentiates the tumor, the liver segments, and on the lateral, you have the 7, and on the medial of this right hepatic vein, you have the 8. The left hepatic vein, on the lateral, it divides it into 2, segment 2, and on the medial, it divides it into 4. So, you would look at it and you would be like, why hasn't he just numbered serially 1, 2, 3, 4? So he's sort of given these numbers based on some streets in Paris, which are numbered quite confusingly for us, but it sort of makes sense in France. Coming to the SIOPEL staging. So this is called the pretext staging, which is the pre-surgical staging. So again, Dr. Sonal would be able to explain with pictures that would make sense. But simply just looking at this picture, you have pretext 1, 2, 3, and 4, and it is based on how many segments of the liver are not sort of occupied by this tumor. So pretext 1 is when you have 3 contiguous sectors that are free. So only one segment is involved, and you have 3 other segments that are free. Pretext 2 is when you have 2 contiguous sectors that are free. And 3 is when you have 1 contiguous free section. And 4 is when you do not have any free sections. And all of this is based on this picture. Now, to make life a little bit more complicated, SIOPEL also has described some annotation factors. And these annotation factors are based on what is the involvement of the hepatic vein, what is the involvement of the portal vein, and some other risk factors. So when you have all 3 hepatic veins that are involved, or you have a tumor thrombus, either sitting in these hepatic veins or in the IVC, it is annotated as V+. If you have portal vein involvement or a tumor thrombus that is sitting in the main portal vein, then it is P+. If there is an extra hepatic spread, it is called as an E+. and F plus if there is a multifocal disease, R plus if the tumor has already ruptured. Now, it is important because based on this, we decide the pretext staging, we put the annotation factors, and then decide what sort of treatment we want to give our child. Now, when we talk about these annotation factors, so we first spoke about the hepatic vein involvement. So if you have a tumor that is obliterating or sort of encasing the hepatic vein, the right, middle, and the left, so it has to involve all three, then it is V plus. But if you have a tumor thrombus in either of these veins or in your IVC, then you can just give it an annotation factor of V plus. Now, portal vein again, if you have a tumor that is encasing or sort of pushing either your right portal vein, left portal vein, or both, then it is a P plus. But again, if you have a tumor thrombus in either of these veins or your main portal vein, then it becomes P plus. So that was the European staging. The North Americans, as they operate first, their staging is quite simple. Stage 1 is when you have been able to completely resect the tumor. Stage 2, if there is microscopic disease that is left behind. 3, if there was a macroscopic, so a gross tumor that is left behind. 4, if it is metastatic. Now, based on all that we've learned so far, COG risk stratifies as very low risk, intermediate, or high risk. Very low risk is when you have favorable histology, which again, Dr. Shefali will talk about. So when you have a pure fetal histology that you've completely resected, then it is a very low risk. Low risk is when you have a stage 1 that is not pure fetal histology, but also not a high risk histopathology like your small cell undifferentiated, or a stage 2. Intermediate risk is when you have a high risk pathology, but it is stage 1 or stage 2, or any stage 3, whether it is pure fetal histology or a non-SCU. High risk is again when it is a stage 4. So if you have distinct mets, eyes shut, it is stage 4. Or if you have a low AFP that is less than 100, then it becomes high risk. SIOPEL sort of risk stratifies as standard risk and high risk. Standard risk is when this tumor is confined to the liver, whether it is pretext 1, 2, 3, and AFP is high. It should be more than 100. Then it all gets grouped under high risk, standard risk. High risk is when you have a pretext 4, which is involving all the 4 segments of the liver, or all the 4 sections of the liver, or if it's a metastatic disease or the AFP is low, or you have any of those annotations that we described. So whether you have V, B, E, F, or R, it directly becomes high risk. Now, we've learned these 2 sort of different cooperative groups that have made the treatment plan. Now, when they have come together, it's called the FIT, so the Pediatric Hepatic International Tumor Trial, which is the latest study that is going on. And it is basically where COG, SIOPEL, and the Japanese group have joined hands, and they have risk stratified it into very low risk, intermediate risk, and high risk. And the whole point of doing the study is where you're trying to see the ones who are doing well, give them less chemo, and sort of get good response with least amount of toxicity. And the ones that don't do well, like your high risk, metastatic, pretext 4, try to intensify the treatment. That's it. Thank you. So I think it's Sonal. So we've now discussed the clinical features. I'd like to call Dr. Sonal, who is very, very important for us, who explains all of this radiology. I've sort of explained all of this with just stick figure diagrams, but Sonal helps us to look at all of this imaging and tell us the exact staging, which becomes very important for treatment. So I'd like to call Dr. Sonal to explain the imaging in hepatoblastomas.
Unfortunately, I didn't realize that he wanted me to email पे भेजना था. अभी फोटो डाउनलोड्स में आया होगा ना? Downloads. Okay.
उसमें नहीं था.
ये अटैच करना है.
Yeah, good afternoon, everyone. I'm Dr. Sonal from the Department of Radiology, and I will talk about the imaging studies and the role of radiology in hepatoblastoma. So the role of radiology basically is to correctly and confidently characterize the lesion. That is, first tell us what is the location of the lesion. So as we know in pediatric solid tumors, sometimes the masses are so large that you cannot even precisely tell what is the origin of the lesion. Is it in the adrenal? Is it in the kidney? Is it in the liver? Then the size, the precise extent, and the relationship to adjacent structures. Next, we must talk about the tumor focality. Is it unifocal, multifocal? Is it restricted to the organ of origin? Or is there locoregional spread to the lymph nodes, peritoneum, distant metastasis to lungs and other sites? Next, we must mention about the complications. Is there vascular obliteration, encasement, invasion, tumor thrombus or tumor rupture? Subsequently, we assess for the surgical resectability. And the last role of radiology is to assess the response post-chemotherapy if a follow-up imaging is required. So in order to give all this information to our oncologists, to our surgeons, what are the tools that we have? So first we have the plain radiograph, which was of course extensively used back in the day. It hardly has any role anymore. Then we have the an ultrasound and color Doppler. Whoa, this time, bring it down. So ultrasound and color Doppler, which is of course extensively used and is the first modality that we use in a child with an abdominal mass, followed by the CT scan of chest, abdomen and pelvis, which is also extensively used after the ultrasound has confirmed that there is a mass. Now, as per world literature, a multiphasic contrast enhanced MRI abdomen has actually overtaken CT scan for the diagnosis and staging of hepatoblastoma. But that is because there is a hepatocyte specific agent which we use as contrast, which is not available in India still. Hence, we are still using CT scan as our go-to test as the gold standard, followed by nuclear medicine. And always remember that comparison with previous imaging should always be done. So we always ask the patient for a previous report, if any. Okay, so moving on to the first thing, which is a plain X-ray radiograph of the abdomen. It is not very helpful, but as you can see here on this plain radiograph, there is a large mass in the abdomen, which is displacing the bowel loops to one side. Also, you can see that there is calcification in the liver. So these are just some small clues, but of course, it is not
really going to help us in diagnosing the location, the extent, any of that. This is a plain chest X-ray which shows lung nodules, which could basically represent metastasis, but that could be from anywhere. So again, these are just clues, not very helpful. Next, we go to an ultrasound abdomen with color Doppler. It is often the first imaging modality that you use in a child with mass because it is easily available. It can be done at the bedside of the child. It is relatively inexpensive. The most important thing is that there is no radiation involved in this modality. So it can just be easily done as a screening tool. There is no sedation required. And also post-treatment, or if there is a surgery or a transplant done for hepatoblastoma, it is again the first modality that we use for operative assessment of the complications. The disadvantage is that it has a very limited field of view. You cannot image the entire abdomen at one go. So if the mass is very large, it may be difficult to ascertain the organ of origin. Again, it is operator dependent and not easily reproducible. So this is the first test that we use, which is ultrasound and color Doppler. Now, when you see a mass in the liver on ultrasound, no questions asked, you must switch on the color Doppler, whether it has been asked for or not. So on the B mode, which is the normal ultrasound mode, you see a solid mass in the abdomen. You ascertain what is the organ of origin. So over here, we can clearly see that it is localized to the right lobe of the liver. What we can also see is that it has a variegated appearance, which means that there are some areas which are bright, that is hyperechoic. There are some areas that are hypoechoic. It may also have calcification within it. So this is a variegated appearance of the mass. And when you switch on the color Doppler, you can easily and correctly identify in which segment of the liver is it located. So here you can see that this mass is playing the middle and the left hepatic vein. So it is situated in the center, that is the left lateral lobe of liver, which is segment 4A or 4B. Now, after you have done that, let us see what, if you see a mass, what is the relationship to the adjacent structures? So we know this is a mass in the liver most likely. It is not doing anything to the kidney. In fact, it is causing scalloping of the upper margin of the kidney. So you know that this is not a mass arising from the kidney. So there are some signs, which I won't go into detail, which tell us that what is the likely organ of origin. Next, you look at the vascularity of the mass by switching on the color Doppler. So here you can see that the mass is very vascular. It has both arterial and venous shunting inside it. So again, that is likely to suggest a malignant mass. And then the last thing is where you can see the vascular complications. So here we can see that the portal vein, the main portal vein, is not showing the adequate color within it, which is suggestive of a portal vein thrombus. Similarly, you can identify a thrombus in the hepatic veins or in the IVC, which will upstage the tumor. Then these are some post-operative complications. As I said, once the child has been operated for hepatoblastoma, if you want to see any complications, be it even something as simple as a collection, a bile leak, a bilioma, or any vascular complication of surgery, again, ultrasound is the first modality that you would use. So this was a child post-surgery for hepatoblastoma, and he developed a portal vein thrombus. So next we move on. So once you have ascertained that, yes, there is this mass in the abdomen, it is arising from the liver, AFP levels are high along with the relevant clinical picture, the next thing we would do is a multiphasic contrast enhanced CT scan of the abdomen and pelvis, and the chest must be included in this because, as Dr. Kriti said, that the chest is the most likely site of metastasis. So in the same test sitting, in the same sedation, you can cover the chest. So what are the advantages of a CT scan? It can give you, it is an anatomic scan. So it can give you superior anatomic detail as to all the points mentioned before, that is the site, the size, vascular structures. Second is, it is a multi-planar imaging method. So you can see the same tumor, the same vascular relationships in both the axial, sagittal, and the coronal planes. Then you can also see the locoregional and distant spread, including what you see in the chest. You can accurately assess surgical planning. As for the surgeon, what is the distance of that tumor from other vital structures, etc. And the last one, which I will talk about a little bit more in detail later, is you can also do a volumetry of the liver. So when you see a large mass which needs to be resected, you also need to know that what will be the residual volume of the liver. Will it be enough for that child? Instead of doing that, should we opt for a transplant instead? So that is what the volumetry will give you the information. And the disadvantages are, of course, that there is very high radiation involved. So it must be used sparingly, only when it is absolutely required. The child will be required to be sedated because there should be absolutely no movement during the scan. And we do give an intravenous contrast medium, which can be nephrotoxic. Hence the need for a pre-test serum creatinine. Now, this is a constant endeavor that we as radiologists have, that when we are dealing with children, you are sending the child for an AFP level. The child is anyways being pricked once. So in the same prick, when you know that it is likely he has a mass in abdomen and he will need a CT scan, please ask for serum creatinine in the same sitting so the child does not have to undergo a second prick. Then we have the fasting rules for sedation, that is 6 hours fasting for solids, 4 hours for semi-solids, and 2 hours for liquids like breast milk. And we give non-ionic iodinated contrast. And it is a multiphasic scan where we acquire the phase in the arterial, portal, venous phase, which also can be tailored based on what we are expecting. Now, I'm just going to give you one imaging pearl. The liver has a dual blood supply. 80% is by the portal vein and 20% is by the hepatic artery. So all malignant liver tumors are hypervascular and they are supplied by the hepatic artery. That is why they will always enhance on the arterial phase when the rest of the liver has not yet enhanced, and then they show washout. So these are the phases. As you can see, this is the first phase, which is the arterial phase, where you can see that there is significant contrast density in the aorta and the hepatic artery. And that is your tumor in the liver, which is showing very bright enhancement as compared to rest of the liver parenchyma. The next phase you take is the portal phase, where you start seeing the portal vein. And again, this is good for the portal and to study the portal anatomy. Now you start seeing that the mass is becoming isodense to the rest of the liver parenchyma. And the last is the venous phase, where it starts becoming hypodense, or it starts showing contrast washout. And these are the characteristic features of a hepatoblastoma, in addition to the fact that there will be intratumoral necrosis, calcification, and this thing which we call as a pseudocapsule formation, which is because of the fibrotic tissue within the hepatoblastoma. Now, Kriti already went through the Coynard segments, but again, just to revise, there is no escaping knowing the liver segments when you are dealing with hepatoblastoma. So it is the portal vein, as she said, which divides it into the superior segments and the inferior segments, and the right hepatic, middle hepatic and left hepatic vein, which divides it into the posterior segments of the right lobe, which is segment 7 and 6, the anterior segments of the right lobe, which is 5 and 8, then the left medial segments, which is 4A and 4B, and the left lateral segments. So in this way, the liver can be conveniently divided into 4 sections. And why is this important? Because your pretext staging depends on that. So now I will just explain this again in brief. As you know that the liver is divided into 4 convenient sections based on the venous anatomy. So a pretext 1 stage is when the liver tumor is confined to one section, and there are 3 contiguous sections which are free of the tumor. Please note the word contiguous, because if you find a lesion in the right anterior lobe, it would not be 3 contiguous sections being free, and that would make it a pretext 2. So in a pretext 2 tumor, it could be confined to 1 or 2 segments, but there should be 2 contiguous. Please understand the continuous use of this word continuous or adjoining, because 2 adjoining sections need to be free of the tumor, which has an impact on the surgical planning. Then stage 3 is where the tumor may occupy 2 or 3 sections, and only 1 section is free of the tumor. And the stage 4 is when there is no contiguous section which is tumor free. So even if you have a lesion in the middle two segments, that would be stage 4 because there are no two contiguous segments that are free of the tumor. Okay, now this is the first case of a 2-year-old male with a mass in abdomen with high AFP levels, where we are suspecting this to be a hepatoblastoma. And as you can see, we have the characteristic imaging findings. But now what we need to do is tell them what is the pretext stage. So here you can see that the tumor is conveniently located behind the plane of the right hepatic vein, behind the plane of the right portal vein. So it is very nicely limited to the right posterior divisions of the right lobe. So this is a characteristic pretext 1 tumor where only one section, that is the right posterior section, is involved and 3 contiguous sections are free. There is no vascular complication, no metastasis. So this child was given 2 cycles of chemotherapy and the follow-up CT showed that there was further reduction in size. And the imaging that we do after that is what we call as the post-text. The post-text staging, the tumor continued to be at stage 1 and it was resected. This is the next case of a 4-year-old male with a mass in abdomen and high AFP levels. Now, again, you can see this large mass with variegated appearance. But now this is occupying the entire right lobe, that is the anterior and the posterior section. So you have 2 sections that are involved, but 2 sections that are free of the tumor. So you have your left medial and the left lateral, which is free of the tumor. So this is a pretext 2 stage. And since it is conveniently limited by the plane of the middle hepatic vein and the right hepatic artery, you can just go ahead and do a right lobe resection. And hopefully you will have the tumor-free left lobe. Now, this is another case where you have this large lesion again, which is seemingly limited to the right lobe of the liver. But here you can see that there is a thrombus, that is a filling defect in the middle hepatic vein. So that is a vascular complication. In addition, you can see that there are these small foci of necrosis or small foci of tumor infiltration that have gone into the left lateral segment as well. So this is not a pretext 2, but it is a pretext 3 tumor because 3 sections are involved and you only have the left medial, that is segment 2 and 3, which is not involved. So just these small foci have now significantly upstaged the tumor. Just these few infiltrates have upstaged the tumor from a pretext 2 to a pretext 3. Now this child was given chemotherapy, and now let us see what has happened after chemotherapy. Unfortunately, even after chemotherapy, we continue to see small amount of this lesion here as we go down also in segment 4B. So unfortunately, this has continued to stay post-text 3, and this child most likely needs an extended right appendectomy. Now, this is another case where we can see that there is this large mass, which you see, this is the right portal vein. It is anterior to that, so it is in segment 5 or 8. You also see that it has gone into the segment 4 of the left lobe. So it is involving 2 sections, right? So what is the pretext? It is involving right anterior and the left lateral. So what is the pretext? Can anybody answer? Come on, is it a pretext 2 or 3 or 1? Those aren't the only options. Correct. So there is so even though there are 2 sections that are free, but they are not 2 contiguous, they are not 2 adjoining sections that are free. So hence this is a pretext 3 because only 1 contiguous section is uninvolved. So this is very, very important to know because this stage, the pretext stage that we give directly correlates with the prognosis. Now, what do you do with an exophytic lesion? So the same the same rule of pretext applies based on where it is arising from. So in this case, it is arising from the undersurface of the liver. Both anterior and posterior sections of the right lobe are involved. So this is pretext 2. Okay, now we have some additions to the pretext and the post-text staging. So V, as we mentioned, is involvement of the veins, that is the IVC or the hepatic veins. M is metastasis, which you may find within the liver, within the chest, within the abdomen. E is extrahepatic abdominal disease, like if you see ascites or peritoneal nodules. L is lymph nodes, so locoregional lymph nodes. H is a very grave complication, which is tumor rupture with intraperitoneal hemorrhage. Now, a clue to diagnosing or not missing this complication is if this tumor, if any hepatoblastoma that you see has a subcapsular extent of the lesion with a bulging of the capsule or an irregular margin of the capsule, or you feel that the fat plane over there is lost, please suspect tumor rupture and look for that carefully. And then you have something called the C, which is involvement of the caudate lobe, which renders it unresectable. P, which is portal vein thrombosis. And F is tumor focality. So, for example, in this large hepatoblastoma, all of the above are there. So there's caudate lobe, there's portal vein, there's tumor focality. So all these are going to, again, upstage your tumor. Okay, now what is also amazing about CT scan is that you can get very detailed vascular anatomy of the arteries, the veins, the portal vein, if there are any anatomic variations, which all help in surgical planning. Again, sometimes surgeons want different measurements, the cavoatrial junction from the portal vein or the liver from the cavoatrial junction, the outer margin, and all these are possible with CT. Now, this is another brilliant tool that we have, which is CT liver volumetry, which if you have the software, it can be applied to any triphasic CT. So here you get, again, as per the Coinard segments, you get a very accurate measurement of the liver volumes of certain segments. And based on this, when you are planning your surgery, if you are planning a resection, you know what will be the residual liver volume and if that will be enough for the baby to survive. Now, the next really good modality is MRI abdomen. Again, it will be a contrast enhanced scan. Now, what is really beneficial of an MRI over a CT is that it has no radiation. It has better tissue characterization, especially in doubtful lesions, in small lesions. It has definitely been proven to be superior to CT for assessing the tumor margins and the vascular invasion. But in our country, as I mentioned before, we are still widely using CT because this very key player, that is the hepatocyte specific contrast agent, has not yet become available in our country. The disadvantages are relative. It has a longer scan time. A CT can be completed in under 5 minutes. MRI can take up to an hour, so you will need a longer sedation period. It is quite movement sensitive. So obviously when the children cannot hold their breath, it becomes a free breathing scan, which may have artifacts. The triplanar reconstruction is not as amazing as CT scan. Of course, for lung parenchymal nodules, it is not a great modality. So in addition to an MRI, you will have to complement it by doing a CT chest. Okay, so again, this is a case of a hepatoblastoma. It is a diffuse hepatoblastoma, which you can see enhancing on the different phases. And in addition, you can see that there are lesions elsewhere also. So this is like a multifocal. And this is one of the nicer tools that an MRI offers, where you can do a diffusion weighted imaging. So this tumor may not be that easy to differentiate it from an infantile hemangioendothelioma or such. But if it shows restricted diffusion, that is suggestive of high cellularity of tumor, and you know that we are dealing with a malignant lesion and not a benign lesion. Okay, so as Dr. Chintan and Dr. Kriti have said, that these are the differential diagnosis of liver masses and in infancy. So it's the same differential that we have to deal with when we are imaging the child. So this is a congenital or an infantile hemangioendothelioma. And what helps us is this imaging pattern, which we call as a centripetal imaging pattern, where the contrast starts enhancing from the periphery of the lesion and slowly the lesion fills up. So yes, this is a differential even on imaging. This is a mesenchymal hamartoma, which will predominantly be a cystic lesion. And this is what an embryonal sarcoma looks like. So yes, although we do have definite image defined criteria, it sometimes may be confusing. And I would just like to end my talk by sharing some final imaging pearls. As I said, the triphasic CT chest, abdomen, pelvis is still the gold standard in India due to lack of availability of hepatocyte-specific contrast. The pre-text and the post-text staging has to be added to a radiology report. If you are using MRI as your diagnostic tool or a staging tool, then you must add CT chest to the imaging protocol. And please remember that post-text can only be applied after neoadjuvant chemotherapy. It is not to be used after resection or surgery. These are the radiology guidelines for post-treatment follow-up imaging. Although there are no universal guidelines being followed, but this is what is suggested. Of course, it has to be tailored to the individual case. So you do not need any imaging follow-up if AFP is normal. And of course, you have to follow the AFP algorithms as our oncologists have explained. But if the AFP is abnormal, then the first thing you need to do is MRI abdomen with a liver-specific contrast agent and a CT scan chest. If these are normal, then we can go ahead with a whole body PET CT to look for distant metastasis and an MRI brain. Please remember that if the AFP is abnormal post-treatment, chest X-rays and ultrasound abdomen do not have any great role. So please go for a higher imaging modality like a CT or an MRI. Thank you. And if there are any questions, I could answer them.
Only question from Sajay said is, if I'm doing right, if left is okay.
Yeah, so that's what I said, that we will give you in the pretext staging, right? So
I don't know about chemotherapy, you got so many questions. Because that time you'll come to know whether it's responding or not. But by the time it reaches to a surgeon, naturally, when something, either transplantation or resection is there, the only question from the radiology hearing and so on that, tell me the volume, remaining volume. Veins are okay, that's it.
Yeah, so of course a good quality of triphasic CT, or as literature and data now shows, that MRI with hepatocyte specific can even pick up a small submillimeter sized lesion which is going beyond the middle hepatic vein. I showed that case of that boy, whether it was crossing the middle hepatic vein even after chemotherapy, it is still going beyond the plane. So of course your left lobe is slightly involved. So as you all went ahead and did an extended right. So those answers can be very well given when we have multidisciplinary team meetings, as we do have in our institute. There must be a lot of discussion between the oncologist, surgeon, and the radiologist in order to reach the correct treatment plan. So next we have Dr. Shefali Jadhav, who is our pathologist over here, and she will talk about the histopathology of hepatoblastomas. Thank you so much.
Good afternoon, everyone. Today I'm going to speak on pathophysiology of hepatoblastoma. A little bit of introduction on that. It's a primary hepatic blastomas tumor that actually retaliates the hepatic development, like mimics the hepatic development. So it's a variable combination of epithelial and mesenchymal component, which I'll be telling along the way. Most frequent liver tumor in childhood. Tumor cells, which I've told earlier, it's recapitulating the embryonal stages. It's staged using the pretext, as Dr. Sonal had said it in brief. There are approximately 1 to 1.5 cases per million. Majority of cases are in the age group of 5 to 6 years. There is a slightly male predominance. Some authors in textbooks and in papers have said it's a slightly more preference to the right lobe, or state that the tumor generally originates from the right hepatic lobe. So this is the tumors which are there in children age-wise. Clinical features which have already been said, just in a gist, that it presents with a mass, and about 5% there is jaundice and other symptoms like anorexia, weight loss, nausea, vomiting. In lab tests, the AFP is very important, which is elevated in 80 to 90%. One more thing in AFP, some labs might just give AFP in 20 to 30,000 or more than 30,000. They might not do a dilution, or the linearity of the machines prevails them for doing it. If possible, always go for a higher dilution, because hepatoblastomas come with 3 lakhs, 4 lakhs AFP. So pathogenesis. Although most hepatoblastomas are sporadic, they are reported to be closely related to genetic syndromes, mostly FAP, Beckwith syndrome, trisomy 18. Here are a plethora of all the genetic or congenital malformation and other conditions associated with hepatoblastomas. Now coming to genetic aberration, the most common genetic mutation seen is the upregulation of WNT beta-catenin and MYC pathways. So other pathways are single nucleotide polymorphism. There is also some work coming regarding these genetic aberrations like MPO promoter gene polymorphism. There is C2T polymorphism of link C673, which is correlated with hepatoblastomas, base excision repair, which are in studies, and there are like going on. So as you can see, this is the main WNT pathway, which is, and the MYC activation, which give rise to hepatoblastoma. The WNT beta-catenin is approximately 60 to 75 responsible for hepatoblastomas. So in gross description, as you can see, it can be a single or a multinodular. Sometimes it may, most of the time it has a well-defined, but grossly variegated one might not. Tumor generally, as you can see, it has a tan brown, which is seen mostly in the fetal type. So in the small cell undifferentiated type may have a variegated appearance. Necrosis and hemorrhage are also seen very common in post chemotherapy specimen. If osteoid present, then the texture can be very firm and gritty and also difficult to cut. So microscopy. So as per the International Pediatric Liver Tumor Consensus classification, it is classified as epithelial mainly and mesenchymal. So the epithelial types are differentiated into fetal, embryonal, small cell, undifferentiated, cholangioblastic, and macrotrabecular pattern. So this is the epithelial pattern. As you can see, there are nests of medium to small size with clear cytoplasm. As you can, these are all glycogen filled, and there can also be seen a foci of extramedullary hematopoiesis. Okay. The subset also has increased mitosis. As you can see, the small darkly stained cells, which are mitosis. This is the embryonal pattern. Embryonal pattern resembles the liver at 6 to 8 weeks of gestation. They are dark and granular cytoplasm, and as you can see, they are totally differentiated from the fetal pattern. They are more dark. They are slightly bigger. The granular cytoplasm, coarse chromatin. Okay, and here extramedullary hematopoiesis is absent. Here also you can see mitosis. As you can see, the small ones. So small cell undifferentiated pattern. The interesting thing with this pattern is most of the times you can also get a normal or a low AFP level. And this has abundant mitosis, apoptosis, and areas of necrosis. Epithelial macrotrabecular pattern. So this pattern also slowly like resembles HCC trabecular pattern. So one has to be very careful in differentiating between the two. And they are trick trabeculae, and see, they are layering, which are formed of 5 to 12 cells. So a cholangioblastic pattern, generally they are like acinides or ducts, which are surrounded by hepatocellular component. And see, in hepatoblastomas, you can also get a mixed pattern of embryonal and fetal. the mesenchymal pattern. The mesenchymal pattern is composed of immature fibrous with osteoid and osteoid-like tissue. In this microscopy, you can see there is a bony tissue here, which makes the specimen very hard and gritty and difficult to cut. So these are the IHC markers which are done in case of if you have a query to differentiate it between HCCs or just between different variant of hepatoblastomas. So this is a small gist of the tumors, the IHCs are positive in what sense? So at the topmost, we can see that keratin has been seen in most of the tumor. Also, the beta catenin nuclear staining in positive in most of the hepatoblastomas. So these are some of the CAP guidelines for hepatoblastomas, which is followed everywhere, including Tata and most of the centers. Basically, it is just a checklist of what happens when a tumor comes. So you have to see whether it's a biopsy or is it a resection specimen. Then you analyze where is the tumor site, which lobe is the site. Then you see whether there is a multifocality or a unifocality. Then you see the macroscopic extent of the tumor. Then you check for whether a chemotherapy was given or not. Okay. Then the microscopy part. Then you see the histologic variant. Then you see for margins, like on gross also you see the margin, whether the margins were involved on gross, and on microscopy you confirm it. Like, and most of the time if we have a doubt, we generally call the surgeons for orientation and also to understand like from where do they necessarily want the margins from. Okay. And also then you will see for the lymphovascular status and the regional lymph nodes, if there were any. Accordingly you stage the tumor, and then along with that the needed IHC. So my takeaway points are here. Hepatoblastoma typically occurs in infants and toddlers, and its etiology has yet there are a lot of discussion. It's a really challenging diagnosis for clinicians, radiologists, and pathologists. About 20% of children with hepatoblastoma do have lung mets. Severe histologic have been associated, which has a different prognosis. The fetal one generally has a very good prognosis, and the ones like undifferentiated small type and mesenchymal not so much. And the current therapeutic approach involves chemotherapy, tumorectomy with partial liver resection and liver transplantation, and hence chemotherapy is induced changes should also be monitored. And thanks. And I'll be giving the mic to Dr. Rochana Mesra, who will be talking regarding chemotherapy. Thank you.
Thank you, Shefali. That was an excellent presentation. Histopathology is one aspect that we clinicians generally don't pay a lot of attention to, because we know that you're looking at those slides and those grosses very, very carefully for us. For a doctor, basically, as a clinician, it is important that we suspect a mass in the abdomen to be the a hepatoblastoma. We've gone through all the clinical features. When would you start suspecting that it is a hepatoblastoma? We've gone through the radiology in great detail to know what is it that you will, what makes you suspect that this is hepatoblastoma, and what are the important things that you need to ask the radiologist that defines whether you will classify this as a very low risk, or even a high risk just based on the radiology itself. Once you've had the diagnosis and we've had Shefali look at the slides, look at the specimen, tumor specimen, and tell us that this is a hepatoblastoma and the different subtypes of it, we are now ready to attack it and treat it. And the reason why we are ready to attack it is because we know that all hepatoblastomas do very well with chemotherapy, and they have a very good survival rate as well. And September being the Cancer Awareness Month, we're all trying to create this awareness for the curability of pediatric cancers. And hepatoblastoma shines out because the very low risk, even the intermediate risks do very well with the treatment that they are offered. So this is one tumor where we want to treat, one tumor where we expect very good survivals, knowing that we've done the proper classification and offered the right treatment for these patients. I will take you through the chemotherapy for standard risk hepatoblastoma. We've just had both Kriti, Sonal tell us about the different risk classifications. So depending on which side of the ocean you are, whether you're on the European side or whether you're on the American side, you might want to treat it differently. But we'll just go through the different options and which one do you think is better for you. So the agenda for this talk is to just go through that classification again and see whether we can have something new that we can use instead of the pretext and the post-text classifications. We look at the importance of chemotherapy, which we firmly believe in. What are the chemotherapeutic agents we can use for hepatoblastoma, the different protocols that exist right now, and which do we think would be the best for a standard risk hepatoblastoma, deals with the side effects and supportive care that we can offer them, and what do we need to monitor in terms of long-term care, and the future directions that is there for hepatoblastoma treatment. So while Sonal and Kriti spoke about pretext, we know that different worlds use different pretext, use the pretext classification differently. So we have the COG, which is the American group, which uses pretext to classify them as very low risk, or standard risk, or they add another category called the intermediate risk group, and then they have the high risk category as well. And it goes by the same thing, using pretext 1 or 2, well-differentiated fetal histology, or pretext 2, 3, and 4 for an intermediate risk, which is unresectable at diagnosis, and also has the other extra hepatic components or the venous or portal involvements that is present. The SIOPL, which is the European body that looks at pediatric tumors, use 3 protocols, that is the SIOPL-3, the SIOPL-4, which is more for higher risk though, and SIOPL-6, but it classifies them only as 2 groups, standard risk and high risk. And we've gone with that. So stage 1, 2, and 3, or pretext 1, 2, and 3 would be standard risk, whereas any metastasis makes it high risk disease for you. The Germans also had their own protocols that has put in for chemotherapeutic agents. They use their group of clinicians from the GPOH, but they also use pretext 1, 2, and 3 as standard risk disease. And the Japanese also use the same thing, but they used it to classify them as low risk, intermediate risk, or high risk. With time in 2020, there was a new collaboration that came in, and they decided to combine all of this together to give you 5 backbones by which they wanted to work with. And they called this the Children Hepatic Tumor International Collaboration, which is also the CHIC classification. And with this, whether if you had metastasis present, you straight away went to the high risk arm, but then they again used it to group as very low risk, intermediate, or high risk. Oops. And this is what they did. So they combined all the children that they had dealt with in all the 5 groups or 4 groups, the study groups, that COG, SIOP, EL, the Germans as well as the Japanese, and then formed these 5 backbones. Backbone 5 just used a low AFP as their denominator, that those children who had low AFPs would also go into the high risk arm, but backbone 1, 2, and 3 were used to classify this as standard or intermediate risk group. What they also used was age, and they also used AFP and the extrahepatic, the VPEFR categories that we discussed, also in their classification to deal with these 3 subgroups. So today what we will, this is how they divided it. Very low risk was, and pretext 1 and 2 became age less than 3 years, became very low risk, whereas intermediate would be 3 to 7 years, and high risk was anything more than 8 years. But if you were a pretext 3 and you were age less than 8 years, you would be intermediate risk group. But if you were more than 8 years, you would then become high risk group. As I said, metastatic disease and AFP less than 100 all classified as high risk disease for you. How did this classification system help as compared to what the SIOP-EL helped us was? So the SIOP-EL3 classification system gave us a survival advantage for standard risk at around 95%. That is where it was. Whereas the event-free survival was also about 93 to 95%. But with this CHIC stratification, we now could have three graphs. The standard risk or the low risk doing extremely well at 100% survival, whereas the intermediate risk was at around 89% and the high risk went down to about 69%. So you could have one category of patients where you could completely divide them and say that this is the group that is going to do extremely well, whatever you may offer these patients. We now move to the SIOP-EL studies. The reason why I've chosen SIOP-EL as our backbone for today's talk is because this is one area where we are very comfortable using. Also, studies have shown us that this, with the minimum amount of chemotherapy, we've managed to get very good results. So SIOP-EL, as it advanced from SIOP-EL1, which is the first study that started, to now about SIOP-EL6, which has come in now, and we'll go through these. SIOP-EL1 used the pretext classification to tell you whether this would work in terms of overall survival. And as you can see clearly in this graph over here, we realized that the pretext 1 and 2 did reasonably well, whereas the survivals fell down as you went into the high-risk category. When we come to SIOP-EL2, SIOP-EL2 decided to use only cisplatin for monotherapy for its standard risk patients. And they told us that yes, even with just this one drug alone, standard risk, the survival that you would get, overall survival at 3 years would be about 91%, which was very good for us. For a disease, when you talk about 90% survivals, is extremely good. And remember, in pediatrics, we always talk about cure rates. We never talk about disease-free survival. What we're trying to tell you is that if the child survives for 5 years beyond the time of detection of the cancer without the disease coming back, then that child is actually cured for life. The chances of relapse are very, very low in these patients. So 91% of your population is likely never to have relapses by using this one single drug itself. SIOP-EL3 used the classification system again, and they decided to randomize it between just using cisplatin, one drug, versus using cisplatin and doxorubicin to see whether we could give them any survival advantage over this. And we will discuss that. And we saw that the 3-year survival rate with cisplatin alone in SIOP-EL3 went up from 91% to 95%, and the overall survival also was much better. The German studies had also got similar survivals in the 90s at that time. So that shows us the importance of chemotherapy. And what we're saying is that chemotherapy with maybe just one drug may be very good for one category or one subclassification of the hepatoblastomas. What's the importance of this chemotherapy? One, it becomes primary treatment for standard risk hepatoblastomas. It can shrink the tumor before surgery. Now, I know that Kriti also mentioned this. I don't know if any of you was paying attention to it, that SIOP and COG differ in their outlooks. Like the Wilms tumors, SIOP prefers to give neoadjuvant chemotherapy, which means that you give them some chemotherapy beforehand, shrink the tumor to make it safe for surgery, and then operate later on, and maybe give another 2 or 3 cycles of chemotherapy to do a mop-up afterwards. Whereas the COG studies believe in upfront resection, the reason being they wanted to have pure tissue for diagnosis, and therefore most of their surgeries may have tumor ruptures, may have other complications associated with it. And then they decide whether they want to give chemotherapy later on or not beyond this. So with this SIOP-EL, you had the advantage of having the tumors shrink before chemotherapy, with the chemotherapy before the surgery. So it gave you a safer field to operate in. Also, it looked at micrometastases also. We know that it is cancer is like roots. We can't have a very well-defined extension. So we can have micrometastases that are present, and systemic chemotherapy will take care of all of that and definitely reduces the risk of recurrence. So what are the effective agents that we can use? We've discussed cisplatin. We also have doxorubicin, vincristine, carboplatin, another platinum compound, 5-FU, irinotecan, temsirolimus, and melphalan. Now, irinotecan, temsirolimus, and welflan are generally reserved for high-risk disease. So we're not going to deal with that. But cisplatin, doxorubicin, and maybe even 5-FU are used for standard risk treatment. And that can be an option that is available. Remember that combination therapy always gives you an increased effectiveness. And that is the rationale they decided to use multiple agents. However, we have had studies to show that maybe even one drug works beautifully as well. So instead of going into details of all the protocols with you, what I've done is just made a small tabular form, and we just go through the different studies and see what they've used and how they've planned their protocols. So the COG, the AHEP 0731, kind of risk stratified as very low risk, intermediate risk, and high risk. With the very low risk, they did upfront surgery as the primary treatment they offered and no chemotherapy thereafter. With low risk and intermediate risk, they offered CDDP, which is cisplatin, 5-FU, and vincristine as 2 cycles after the primary surgery was done. And with intermediate risk, they did the surgery after 2 to 4 cycles, and they gave about 6 to 8 cycles in all. With the high-risk disease, which will be covered by Dr. Chintan later on, they used a different regimen. The SIOP people, the European people, chose to give 6 cycles of cisplatin alone for standard risk disease, and they did the surgery after 4 cycles. So majority got chemotherapy upfront, then surgery, and then 2 cycles of chemotherapy later on. I'm not dealing with high risk, so I'm going to skip that next point. The Germans also preferred to use cisplatin, but they added doxorubicin and they used 3 to 4 cycles and did the surgery after 2 to 3 cycles once they thought that the tumor was resectable for them. And the Japanese used cisplatin, but they also used pyrarubicin, which is another anthracyclines for 4 cycles. For the pretext one, which is low-risk disease, they did surgery up front, but still gave 4 cycles later on. And for pretext 2 and 3, they used cisplatin, pyrarubicin, or cisplatin with some other drug combinations and chose to delay surgery after 2 to 3 cycles as well. And what was the difference? So with survival with the COG study, which is the first study, they had survival, the event-free survival at around 83%, and the overall survival stood at around 90% with these. But remember that they were using at least 3 agents over there. The side effects on supportive care of chemotherapy, I'm just going to leave the SIOP for later on because I think that makes a better impact when we discuss it later on. So what are the side effects of chemotherapy? The common side effects, we all talk about this, nausea, vomiting with all our children, and cisplatin and carboplatin, both are drugs which are highly emetogenic. So they need a lot of care in terms of nausea and vomiting, and sometimes they even have delayed vomiting. So once the chemo finishes, even after that, they could end up having prolonged vomiting episodes, and we need to look into that. Fatigue, hair loss, and immune suppression, which are common side effects of all chemotherapies. But specific to the cisplatin, the platinum compounds, is sensory neural hearing loss. So our children, when they get repeated cycles of chemotherapy, especially when they're so young also, we have to monitor for their hearing for these children. They get kidney damage, which is generally renal tubular acidosis. So we have to watch out, or glomerular damage that happens for these children. So you have to keep watching out for their kidney functions as well. Myelosuppression, especially with carboplatin. So carboplatin is more myelosuppressive than cisplatin, though both are equally toxic. They have these side effects of myelosuppression, and carboplatin generally is less ototoxic than cisplatin. By saying less ototoxic doesn't mean that it is not ototoxic, it is less ototoxic. And then sometimes you have long-term cardiac complications, especially with the anthracyclines. So then even if you've cured these children, we will need to keep monitoring them lifelong to see whether they develop these side effects later on as well. So the reason why I chose to talk about cisplatin later on was because there was a randomized study to look at cisplatin versus cisplatin plus doxorubicin for standard risk hepatoblastoma. And what you can see in this graph over here is that there is no difference between cisplatin or cisplatin doxorubicin. So the survivals over here do not change either event-free survival or overall survival, proving that one drug enough is good enough. So the COG using 3 drugs, which is cisplatin, 5-FU, and vincristine, or the Germans using cisplatin and doxorubicin, or the SIOP protocol saying that cisplatin is just good enough as one agent, this study proves that we can actually do away with the other agents and still get a survival benefit for our patients. So what is the way forward? We've already looked at history. We've dealt with SIOPL 1, 2, 3. With 3 and the subsequent randomized study, we proved that for standard risk, cisplatin alone would be very good. Now, remember, to call it standard risk, you have to have an MDT together. You have to have a very good radiologist. You have to have a very good pathologist who can sit with you and dissect those scans and the biopsy specimens, the tumor tissue, to make sure that you're not missing a high risk. So make sure that you have a good MDT with this. The way we are moving forward is we have SIOPL4, which is for high-risk neuroblastomas, and I'm sure Chintan will talk about that. We have SIOPL5, which talks about hepatocellular carcinomas, one topic that we've not covered today because we know it's very, very rare in children. And we talk about SIOPL6. SIOPL6 uses this cisplatin arm only, but now tries to decrease the side effects by using sodium thiosulfate to prevent or decrease the ototoxicity that comes in. So from here, we are now moving forward to trying to decrease the side effects of our medications, because we know we've already got a very good survival benefit with just one agent alone with this. So this is how the SIOPL protocol will look like, and it is going to use either cisplatin alone or cisplatin with the sodium thiosulfate, and then decide how we think that this will decrease the ototoxicity for these patients. One area that I haven't touched about, we're all talking about cure rates, we're all talking about primary resection. We haven't talked about liver transplant. Now in pediatrics, in standard risk hepatoblastomas, we generally don't expect that we will need liver transplants. But there are some indications where we may need to think about it. And the indication would be if there is a unifocal centrally located tumor, which involves mainly the hilar structures or the main hepatic vein, or if it's the caudate lobe which is involved, which they said is not resectable, then in those cases, you will have to think about hepatic transplant. If there is any patient where the surgeon has doubts about a complete resection, there you should start talking about liver transplant to the patients up front. If there's progression of disease of chemotherapy or a non-response to chemotherapy, again, these patients will shift to the high-risk arm, and then you may need to talk about this. These are kind of relative indications, not absolute indications, but this is somewhere where we'll need to start talking to the family about this as well. So I'm going to conclude my study over here saying that chemotherapy plays a very crucial role in treatment of standard risk hepatoblastomas. Survival rates are actually improving with just single agent drugs itself. Newer protocols that are coming in now aim to decrease the toxicity. And even these different collaborative groups are now combining to form one big group so that they can work together for the treatment benefit for our patients. A multidisciplinary team approach involving surgeons and supportive care and a pathologist and the radiologist is absolutely essential if you want to offer good care to these patients. And regular follow-up will be absolutely necessary to monitor for recurrence and to ensure that we can give them the best outcomes. With that hope, faith, love, awareness, and strength, we believe that we will work towards cure, we will win, and we will triumph over pediatric cancers. Thank you so much for your patient hearing. September is again the awareness month for us for pediatric cancers, and I hope by this talk, we will have created an awareness so that the next hepatoblastoma comes up as an early standard risk hepatoblastoma and does not need a liver transplant. Thank you so much. Any questions? Otherwise, I will introduce my next speaker. That's Dr. Chintan Vyas. Dr. Chintan, you heard him in the beginning of the session today. He's a consultant in pediatric hematology, oncology, and bone marrow transplants at SRCC Children's Hospital. And he will take the topic of dealing with agents in high-risk treatment. Sir. No, so sodium thiosulfate is not used routinely right now, sir. No, it's not used, sir, right now. It's difficult to procure. They're trying to procure it. That's a different chemotherapeutic agent. Yes, yeah, we use that for bone marrow transplants. Thiotepa is a very different agent, sir. Sodium thiosulfate is something. Yeah. No, not the same family of drugs.
Thank you very much, Dr. Ruchira, for getting audience an overview of the treatment part of the hepatoblastoma. I think my role is very limited because the role of high-risk hepatoblastoma chemotherapy is not just a chemotherapy, but it's a multidisciplinary team approach, again, with a very good liver surgeon, which we require. Give me a second. So while the presentation is being loaded, I would like to just tell you that the reason why we divide hepatoblastoma between standard risk and high risk is that the prognosis is quite different. And we always know that the prognosis of the child, which makes the patient and the family most concerned. So why the prognosis is so different in the hepatoblastoma per se compared to the other tumors? Let's we talk about the blood cancers. The prognostic difference between the blood cancer and the liver tumor, the standard risk and high risk difference. So the prognosis between the blood cancer is standard risk and high risk is maybe, let's say, it's 20 to 30%. But when we talk about the liver tumor in hepatoblastoma, the prognosis between the high risk or very high risk hepatoblastoma versus the standard risk hepatoblastoma is huge. The same things goes for the neuroblastoma. The prognosis between the standard risk neuroblastoma and the high risk neuroblastoma is huge. Like one is like 100% or 90% survival, while the other is 20 or 30% survival. And that is why we wanted to highlight the importance of treating the high risk hepatoblastoma in a setting where we can offer everything to achieve at least a substantial standard of care. Now, what are the high risk hepatoblastoma? High risk hepatoblastoma is the one who are pretext 4. We know about the pretext now, or let us say stage 4. So if you don't remember pretext 4, the tumor which is left with no single quadrant being involved. So all the quadrants or the adjacent quadrants are involved. That is pretext 4, or a stage 4 disease where you know that is a metastatic disease. These are the tumors which are high risk. Now, when you have less than pretext 4, means whether it is pretext 3 or pretext 2, but you have something which is abnormal in terms of the resection ability. That means that portal vein, hepatic veins, lymph nodes, some of the lobes like caudate lobes and all, those patients in whom where we'll not be able to achieve the complete resection, which will affect the outcome of the patient, that is the one which makes the patient high risk. And again, I have told you that there's a catch here. I don't know if someone can pick up what is wrong in this slide. What is the typographical error in this slide? If anyone would like to type or answer. So AFP more than 100. So I have intentionally put this as just to keep you awake. So AFP less than 100 is high risk. AFP more than 100 is not high risk. AFP less than 100 is high risk. So that is very important to remember. Now, rationale of chemo, we have already heard from Dr. Ruchira. As we know that surgery is again very important part of the high-risk hepatoblastoma treatment. High-risk hepatoblastoma or any hepatoblastoma is very chemosensitive, but the cure rates differs, and that was the main purpose of telling me before that the cure rates of high-risk hepatoblastoma compared to the standard risk hepatoblastoma is very different. Now, what we know from our experience from the last maybe 40, 50 years of the treatment of hepatoblastoma, that one drug or one trial or one country will not be able to make the difference. So you need a collaborative efforts, and that's why the multiple countries, and not even countries, continents are coming together. Previously, it was between America and Europe, but now the multiple multiple continents also are coming together for treatment of hepatoblastoma. Now, when we talk about the collaborative trials, the collaborative trials are the one which usually are between the different continents. That some people have used cisplatin-based chemotherapy with vincristine and 5-FU, and some of the countries have used cytopil-based chemotherapy. That is a different approach. This we have already seen by Dr. Ruchira's slide, that what are the collaborative groups which we know in the treatment of hepatoblastoma. But one thing which I wanted to highlight, that the drugs which has not been used in the previous setting, where the patient has a progressive disease, in those settings we can use the drugs which has like if you have people have used cisplatin or cisplatin doxorubicin based chemotherapy, we should use the more aggressive regimen like carboplatin and doxorubicin based chemotherapy, or intensive cisplatin based chemotherapy. This is just a flow chart that how we go. When we see any high risk hepatoblastoma patient, we definitely offer chemotherapy first, and then we offer the surgery versus liver transplant. Surgery versus liver transplant, Dr. Rasik sir and Dr. Ashok will explain you where we need surgery, where we need liver transplant. So I won't go in that much detail, but what I'll explain you is about the chemotherapy regimen. Chemotherapy regimen in the high risk hepatoblastoma is particularly not just a cisplatin monotherapy or a cisplatin carboplatin doxorubicin based monotherapy. It's sometimes dose intensive cisplatin or a carboplatin doxorubicin in combination with cisplatin. As I have told you, the outcome is very much different between 20 to 30% versus 60% between standard risk or high risk, or let's say stage 3 or stage 4 disease. And the complete resection makes a lot of difference. So the complete resection means that if you have achieved R0 resection, means if you have achieved marginal resection and the margins are also negative, and then there is no gross residual disease left. In such cases, or there is a metastatic CR, means if there is a metastasis, the metastasis has been removed. That means it is a complete resection. In such cases, your 5-year event-free survival is very good. But if you do not achieve the complete resection, or if your metastasis is not resolved, and if you are not able to get rid of the metastasis, then the outcome is very dismal. This is a very old trial which used carbo, IFOS, and doxo, and the outcomes are again different between the different stage groups. This is a very important thing which we need to remember, that disease-free survival depends on the prognostic factors, and the prognostic factors are the one which makes the patient high risk. If the tumor size is less than 1,000 versus more than 1,000, one or two liver lobes, 1 versus 2 liver lobes, or multifocal tumor, histological subtype. I must say that previous speakers on the pathology must have explained you about the bad histological variants like small cell fetal variant, growth pattern in the liver, vascular invasion, particularly portal vein, hepatic vein, distant metastasis like stage 4 disease, surgical radicability, means surgical resection, alpha fetoprotein levels, as I have mentioned before, and response to chemotherapy is important. Now, SIOPL2 trial, we have known that, as Dr. Chira suggested, that standard risk arm we use to these type of treatment. But what we do in the high risk arm in the SIOPL2, which is the commonest trial which was used till now, it used the super platter regimen, and the super platter regimen I'll just explain you in coming slides. What was the aim of SIOPL2 trial? SIOPL1 was predominantly just a baseline pilot trial, but SIOPL2 to validate the risk stratification model and to test the efficacy of intensified chemo for high risk arm. Intensified means stronger chemo, higher doses, more frequent dose, less frequent interval, and dose intense chemo. So high risk hepatoblastoma, they have used carboplatin with doxorubicin and cisplatin in the span of 14 days. So quite intensive chemo. 2 courses of such chemo, cisplatin, then carbodoxo, cisplatin, then carbodoxo. Every 14 days, the patient is receiving chemotherapy. This is an arm. So we give 3 or 4 cycles of cisplatin carbodoxo based chemotherapy every 14 days, and then we try to assess the surgical resectability, aiming a complete resection. At the same time, if there is a metastatic disease, we aim that metastatic CR has been achieved, and then we give further 2 cycles of chemo. Again, as I've told you, the response is based on your resection ability, and resection ability is based on your response to chemotherapy as well as the upfront disease staging, whether it was a pretext 1, 2, 3, 4, multifocal, the portal vein involvement, lymphatic or node involvement, and the metastasis. If we do not achieve the complete response, the outcomes are not as good as it has been described in this slide, that if we achieve standard risk arm, the outcomes are nearly 90% versus high risk arm, the outcomes are 48 to 50% only. Huge difference. So SIOPL2 conclusion say that cisplatin alone is not sufficient, and we have to add doxorubicin with carboplatin. Now SIOPL3 high risk arm, again the high risk, the categories is same, but the treatment strategy is same what I have described you. Cisplatin with carbodoxo every 14 days, 4 cycles in the as a neoadjuvant setting, means before surgery, and then 2 cycles later on. So total 8 chemotherapy blocks before surgery and 3 or 4 chemotherapy blocks after surgery. The response rate, if we are able to achieve the complete resection, it is 70 to 80%. If we are not able to achieve the complete resection, the outcome is not that great. Again, 3-year overall survival, pretext 4, the outcome is 70%, metastatic disease outcome is 60%. That is only if we are able to achieve the complete resection and AFP coming down nicely and metastatic CR. The one drug which has been tried as a wonder is irinotecan, and this drug has been used in relapse refractory setting. Cumulative dose is not an issue. It is outpatient based drug. We can give it in a daycare also, and possible to use even in a post-transplant setting where you are dealing with a lot of immunosuppression. Post-transplant means post-liver transplant, dealing with a lot of immunosuppression and infections risk, and that time also irinotecan can be smoothly used. Just a 1 hour infusion can be given in daycare, no significant toxicities, but it's a wonder drug. Now, irinotecan, even as a maintenance therapy, has been used for high-risk hepatoblastoma. Definitely for the relapse setting, it works very nicely. Outcomes of irinotecan-based chemotherapy, there are some trials which has been used. Sometimes they have been used in combination with vincristine and irinotecan. Now, in which condition will we use the chemoembolization or a hepatic embolization technique by using TACE? So I'm not the expert in the intervention radiologist, but this is one of the technique where we need to use in the high risk arm. Let's say if you are not able to resect the liver completely, or the liver transplantation is also not being able to achieve at that particular time where you need to do something as a bridge to liver transplant, that time probably these intervention radiology technique may help. And it's just a chemoembolization type of technique where you can use chemo with intervention radiology approach, and can help to achieve some sort of bridge to get for the liver to go for the liver transplant. Sometimes it can be used in a relapse setting where we don't have an option of liver transplant, or a liver is not remained itself sufficient enough for any further surgery, so we can use this technique. Toxicities of TACE is very minimal, just a bit of myelosuppression, nausea, vomiting, sometimes transient elevation of the bilirubin. So this is a technique where we can use in high risk hepatoblastoma. So chemoembolization is a feasible and associated with tolerable toxicity, is therapeutic alternative for unresectable tumors after systemic chemotherapy. Now, the last trial which is used nowadays in limited centers where the supportive care is not a problem is SIOPL4. It's a very, very, very high risk treatment. It requires a lot of supportive care, a lot of infections as a comorbidities, a lot of mucositis, and sometimes the risk of mortality also. So what was this SIOPL4 trial is all about? it is mainly to achieve the resectability, because if we are not able to achieve the resectability after some cycles of chemotherapy, we are lost again. So that was the main purpose of achieving for planning this cycle for high risk trial. So this trial, C means cisplatin and the D is doxorubicin. So we give dose intense cisplatin every week for 3 weeks, and then give a break of 3 weeks, and then again every week for 3 weeks, coupled with doxorubicin on the second week. So total number of chemos, you can see that 15 chemos before surgery, and then again 10 to 13 chemos after surgery. So quite an intensive regimen we have used in some of our patients. The resectability with this type of regimen is very good. Previously, it was only 70%, but with this type of regimen, the resectability has been achieved as good as 80 to 90%. And that was the only aim for giving such a high dose chemotherapy in such a young child. Otherwise, we would never aim to give such a dose intensive chemotherapy in a young child. But we know that metastatic CR is most important to achieve the long-term remission, and we know that complete resection is most important to achieve the long-term remission. That is why we use. Now, when we use this type of chemotherapy, we are bound to have a long-term side effect. We are bound to have hearing loss. We are bound to have cardiotoxicities, but that requires a close follow-up, frequent BERA for the hearing evaluation, frequent echoes, and if we keep on monitoring the late effects, then probably we are not in a trouble. Sodium thiosulfate has been used in cisplatin setting. Dextrazoxine has been used for the doxorubicin side effects, but these drugs are not available in India. So we then just need to time the duration of these chemotherapy so that it doesn't cause toxicities, and we need to repeat the echoes so that the anthracycline doesn't cause toxicities. So I'll end here, and I'll leave to my surgeons now that we have tried to do something resectable. Now the ball is in your court, and I think that is the final aim. If we do not have good surgeons, we are not existent in hepatoblastoma. That is the bottom line. I leave to Dr. Rasik Shah for the further talk. Sir is a senior consultant heading our pediatric transplant surgery unit, and I think he will tell you best about the surgical aspects. Thank you very much.
Thank you, Chintan. I'm pediatric surgeon, but not transplant surgeon. Just to correct Dr. Chintan, we have transplant surgeon Dr. Ashok Thorat over here, who helps us for all our liver surgeries. I am going to tell you about surgical management of hepatoblastoma. So I am going to cover basically principles. Dr. Thorat will add upon how to do liver resection and about liver transplant also. So let's go through the principles of hepatoblastoma. So far, I think radiology, chemotherapy, pathology, everything is covered well. So let's see about surgical principles. So all this has been discussed well by radiologists as well as pathologists, but we still need to go through again once before we go further. So there are 8 lobes. I'll go directly to the types of surgery. Let's say that. Okay. So when it is pretext 1, we can do either left lateral segmentectomy. You can see that is the left hepatic vein, which will divide the left lobe of the liver into 1, 2, 3, 4. So if the disease is only in the left segment or left lateral lobe, then one can do left lateral segmentectomy, or one can do, if it is right lobe posterior part or 6 and 7 segment affected, one can do right lateral segmentectomy. Then we can have pretext 2, where there are 2 contiguous lobes or part of the segments of the liver which are involved. Then one can do either right hepatectomy. Right will be right to the portal vein, right to the middle hepatic vein. If we excise the segment 5, 6, 7, 8, it will be called as a right hepatectomy. And if we do 2, 3, 4, then it will be left hepatectomy. If it is Then it comes to the extended hepatectomy. So if the middle vein is affected, whether the disease is on right side or left side, then we'll have to do either right extended hepatectomy or left extended hepatectomy. And if we have segment 4, 5 affected, 4B and 5, then it will be more of central tumor, and then we may have to do non-anatomical resection in such a scenario. So these are the type of surgical resection which one needs to do. So this is already been discussed, so we will not go through that again. So let's go to the biopsy part. Now biopsy is recommended in COG, pretext 3 and 4, or SIAPL in all, because we give chemotherapy and then operate in them. All trials diagnostic biopsy in hepatoblastoma has proven to be safe and reliable because there were no episodes of tumor seeding. There are very less complication. And earlier it was open biopsy. Now we do closed biopsy using true cut needle. So why we do biopsy? To rule out any benign tumors. And sometimes if there is a combination of hepatoblastoma with HCC or HCC, so that we know exactly before we give chemotherapy. And it is always better to do under image guidance with percutaneous coaxial technique. So we can have multiple pass and adequate tissue. At the end, one can push thrombogenic plug or gelatin foam to close the tract. And one should be careful while doing the biopsy that you don't go through the normal part of the liver which you want to leave behind after the surgery. So if I'm going to do right hepatectomy, I should go from the right side only and not to cross over, because otherwise we can have problem after the surgery with the recurrence. And if you are not able to do that, one may consider even laparoscopic biopsy in some of the patients, where if we are not getting the right plane to do the biopsy. And you have to have minimum 2 to 3 codes so that we can give accurate report. Standard recommendation is 5 to 8 codes. Then these are the general principles. Surgery plays a critical role in the management of hepatoblastoma. Complete resection is the only way to achieve cure. And always remember this sentence, complete resection is the only way to achieve the cure. If we are not able to do by liver resection, then is the liver transplant. So orthotopic liver transplantation provides promising outcome for those with unresectable hepatoblastoma. Surgical techniques and surgical tools have advanced in past decades, which has greatly facilitated precision hepatectomies and metastectomies. The 5-year overall survival rate for hepatoblastoma is approximately 80%, and those who underwent partial hepatectomy achieves as high as 91%. And as Dr. Ruchira said, in some of the patients, it can even lead to about 100%. Margin of 1 centimeter from the tumor, that is what we want to have, but presence of microscopic tumor residue in patients who have received pre-op chemotherapy has no adverse events. However, such data does not, we don't have the data for those patients who have not received chemotherapy, and if they undergo the surgery, and if this comes positive, what will be the future outcome, that we do not know today because we don't have adequate data. But after giving chemo, if there is microscopic residue, there is no adverse outcome. Hepatic veins are secured before parenchymal dissection, or one can go through the parenchyma, but it can lead to severe blood loss. So it is always better to have hepatic vein control before you start dividing the parenchyma. Parenchymal dissection it should be along the line of ischemia. Blood loss can be minimized by adherence of the above technical principle, as well as maintenance of a low central venous pressure with Trendelenburg position and application of Pringle maneuver. Now, Pringle maneuver, you can either do 30 to 45 minutes together, but better than that would be 10 to 15 minutes occlusion, followed by 5 to 10 minutes of blood flow. Specialized equipment like ultrasonic PUSA type dissector, water knife, or argon beam, all this can help you, but you can do even with just Kelly crush. Intraoperative ultrasound examination can determine safe resection plan, assuring complete tumor removal, and it is reliable detection. So that the idea is to do complete resection, not to leave behind as far as possible. Topical thromboblastic agents such as fibrin glue or special sponge sealants are used to cover the hepatic resection plane. So this was in general about the principles. We will see the settings, like if there is a tumor rupture, then what one should do. Basically, it will lead to bleeding, and it can be significant. So intracapsular hematoma may tamponate the bleeding, but occasionally it can be a free bleeding into the peritoneal cavity with hypovolemic shock. If we should correct as quickly as possible, then either do percutaneous embolization, and if that is not feasible, then operative control of hemorrhage. And we have to be careful that we are not heroic and damage something irreversible. It is why the problem with hemorrhage is there is massive blood loss, and it increases the risk of tumor recurrence, surgical complication, and mortality. Now, what is the difference between atypical non-anatomic resection and standard? We discuss about standard, but atypical in general is not recommended, because 38% of patients who had atypical resection were found to have post-resection residual tumor. So as far as possible, don't do it. One of the reasons they said is the hepatocyte growth factor can create a problem. And atypical resection can lead to, some of them may be for multifocal tumor and can have problems. So as far as possible, do anatomic resection. Then some of the patient may have lung metastasis. So 20% of the patient are found to have lung metastasis at the time of diagnosis. Now, most of them, means more than 50%, will resolve with just chemotherapy and they don't need anything more. Metastatectomy for residual pulmonary nodule should be done if they don't regress with chemotherapy. Aggressive surgical resection gives better outcome, long-term outcome. Only thing which will contradict will be insufficient pulmonary function after the metastatectomy. If we think that will be the contraindication, and it should be always removed prior to the liver transplantation. It can be done either by thoracotomy or thoracoscopically, or advantage of thoracotomy is manually you can fill it. And if you are going to do it thoracoscopically, one can do CT guided injection of methylene blue or blood patch or hook wire in the lesion. This is for the deep lesion. If the lesion is superficial, you can see it, you don't need to do this maneuver. Intraoperative ICG fluorescence will be helpful in detection of the lung metastasis. Very small metastasis also can be detected on ICG. If you are going to use ICG, use 0.5 milligram per kilogram, and it should be injected 1 to 4 days prior to the surgery. And if it is at the depth of more than 10 millimeter, it will not be detected. So that's about lung metastasis. These are the complications of the lung resection which can happen: bleeding, intra post-op, and which can lead to even cardiac arrest and a lot of other issues. The blood flow, the post-operative sequelae of intra-op inflow or outflow obstruction. So inflow will be portal vein problems, thrombosis or injury, and outflow will be pulmonary hepatic vein obstruction or thrombosis. Now, when you put any stitches to control the bleeding, you have to be careful that you don't damage the outflow or hepatic veins. The liver failure can happen with coagulopathy. It can lead to coagulopathy, hypoglycemia, or ascites, particularly if the remnant is less than 25%. It can lead to even encephalopathy. Bile leak can happen. Particularly, this is common. Particularly, we will see about the bile leak in one of the slides later. Infection and miscellaneous like adhesive obstruction, they are standard, nothing particular in them. Bile leak can happen in 10 to 12%, and you have to be very careful while dissecting, and you should put clips wherever you think there is a bile duct. Particularly if you do anatomic resection, it is less likely to happen. It can be minor or major. Minor you can leave behind. Major, if it is there, one may put a Roux-en-Y loop so that there is no biliary bile leak. So we said that avoid non-anatomic resection as far as possible. If there is any doubt, do retrograde cholangiogram and confirm, and if required, take care of that intra-op. Any complication which is detected intra-op can be taken care. If it is post-op, then it is difficult. The drain helps because you can control it well. So if bile leak continues, then you have to think whether you have, there is any retained segment which is excluded from biliary drainage system, whether there is any iatrogenic occlusion, clip, ligature, thermal injury, hematoma, stone, residual tumor, ischemic stricture. And if it continues more than 100 ml, more than 10 days, then one has to think and take care of it. You may have to re-explore or do ERCP or something. Surgery for relapse in the liver. So management of relapse tumor varied across the groups. SAPL studies said only 5% of patients who have achieved complete remission had a relapse and were treated with salvage chemotherapy and surgery. And the long-term survival was not there, but short-term survival of 17 months was only achieved. And in some of these patients, one can consider liver transplant, but the results are not great. It is about 30% compared to 82% in primary liver transplant. So upfront, one has to make sure that whether you want to go ahead and do primary liver transplant or liver resection, because the results of liver transplants are very good. 3D reconstruction helps the surgeon to understand the local anatomy, and it particularly in complex hepatic tumors and extended liver resection, one should do this 3D reconstruction and plan the surgery. ICG imaging, we did discuss a little bit about that in lung metastasis. So similarly, even in liver resection, it can help. It was started in adults, and now even in children, it can be done. Even the lymph nodes one can detect, even multifocal disease can be detected. You inject 0.5 to 1 milligram per kilogram intravenously 48 to 72 hours before surgery. Then is the laparoscopic liver resection. Now it can be done, but you need to have adequate experience. You need to have a laparoscopic ultrasound, and then intermittent inflow occlusion and low CV central venous pressure anesthesia is helpful. Energy devices and staplers are required. Particularly for deeper, you need to have PUSA, laparoscopic PUSA. The lung relapse, again, it can be solitary or multiple, unilateral or bilateral. And if it is there, basically you go in and excise, you give chemotherapy, and if that does not work, you go ahead and do the surgery. The results are in SAPL 59 cases, 31 patient achieved second complete revision. The remaining of that 27 had surgery, and in 15, one could achieve complete remission. And last slide probably. So if the liver remnant is low, then one can do stage liver resection. In first stage, what you do is you ligate the portal vein almost completely and split the liver and put this in the silastic pouch. And then after about 1 to 2 weeks, you go in again and complete the resection. What has been seen that functional liver residue increases in the size from 60 to 102%. Now in children, one can do just portal vein embolization, and that may be adequate. In general, in children, probably this is not required, but if it is required, one can do it. one of the surgeon has done 5 cases and he has reported that. So this was in general about role of surgery in hepatoblastoma. And I'll call upon our liver transplant surgeon as well as liver surgeon, Dr. Ashok Thorat. He is preoperative biopsy is necessary if alpha protein is very high in cases of inoperable tumors, which are planned for neoadjuvant chemotherapy. So yes, because you want to rule out the transition of hepatoblastoma to HCC or HCC. You don't want to miss it basically, and it is better to do it. Dr. Ashok Thorat. So Dr. Ashok Thorat is trained at Taiwan for 6 years and he is in India for last 5 years. And he is basically liver surgeon, does a lot of liver resection, and he is with us at SRCC for last 2.5 years. And we have done a lot of liver resection together and even transplant. We have done 19 transplant and about
18 survived.
18 survived. And we have done maybe about 8-10 liver resection in last 5-6 years. Please go ahead.
Thank you so much, Dr. Ashok here. I'm unit in charge of liver transplantation here at SRCC. We basically the central team in intra-NH. We have units in Delhi, in Bangalore and Calcutta. And of course here we run the exclusive pediatric transplantation department. And in hepatic surgery, we team up, me and Dr. Rasik, Shah, we team up. It's a very common topic, in hepatoblastoma, there are only 2 things, either you give chemotherapy and surgery. So overlapping thing, whatever, like Professor Rasik already told. So I'm just going to run through this thing because I think hepatoblastoma, treatment of hepatoblastoma is like a battle, and the battle is not won by one warrior. It's always a group of warriors, a form army. And our battle starts with our first commanders, like our oncologist, which prepared the patient, and only the last nail is hammered by surgeons. So as we already gone through this, I'm not going to talk about it. So of course, for any surgery, not just liver, for that matter, any surgery, the knowledge of anatomical knowledge is prerequisite, and it is not different for the liver anatomy, the segments and everything you should know. Pretext is already being explained, pre-treatment and extent of the disease, which is very important. There is already in last all this lecture, it has been discussed in detail. So I'll just run through the slide. So these are the segments, coinor segment, 8 segments. So segmented anatomy. Now there are one of such tumors where the size doesn't matter, whatever size of the tumor, as long as you can leave behind enough normal tissue. So any tumor can be operable. So whatever size, centimeter, and as long as the patient doesn't have any mets, extrahepatic mets, so it is operable. So again, this pretext system already been mentioned. What happened? Am I too close? Okay. So there are 8 segments. So always go for segmental one. The non-anatomical, hepatectomy. It is. I think it is not a hepatectomy. So definitely it will not help. The recurrence rate is very high. So it is always anatomical. And if you cannot do anatomical for something, so next thing you should go for liver transplantation because it offers the complete cure. So this pretext system is already being told. So I will not go through it. But extrahepatic disease is a rare situation occurring less than 5% of the patients with hepatoblastoma. Simple aside is not considered as an extrahepatic disease because sometimes tumor is so large that it will press upon the hepatic vein, so that can be a transmitted. And rupture of the tumor during surgery is not considered as tumor rupture because tumor rupture altogether is different than spontaneous. So there are chances the cells will spread, but during surgery, sometimes it happens, but still patient can have good outcome. Tumor close to the hilar structure leading to compression of local structure may lead to classification challenges. Tumor that are pushing the vascular structures may cause pressure changes that can mimic invasion on imaging. Now the timing and extent of surgical resection, primary or delayed surgery, background, in order to which consists establish a common international approach. So, it's already been discussed by Dr. Uchira and previous and Dr. Sisha just done to it. Then there are 4 classes: very low risk, intermediate, and high risk. So general remarks about any hepatoblastoma surgery: the size of tumor is not a contraindication. Tumor resectability depends on surgical expertise. Knowledge of liver anatomy, expensive liver surgery, and specialized equipment are absolutely necessary. Without that, no liver surgery is possible. Important surgical aspect: the traditionally recommended 1 cm margin, normal parenchyma is sometimes difficult to achieve, especially in young children. Especially tumor is very big, and whether it's small margin, for example, few millimeter, will be sufficient for cure. One study detected, no such difference was detected in local recurrence. The positive margin on the tumor side doesn't necessarily mean the presence of tumor cell on the patient side, because when you do liver resection that time, either you're doing Kelly crush or CUSA or by anything, you always clear your 2 to 3 millimeter margin of the liver. So even though the cuts up is there on that side, because you use your high thermal probes and everything, so most of the time the cut surface liver becomes necrotic. 2 to 3 millimeter of liver you already clear, and around the 2 to 3 millimeter you burn. So it is still it is not significant causing recurrence. Liver transplant for hepatoblastoma and timing. Now 10 to 20%, as mentioned even before, around 10-20% of the all hepatoblastoma cases require liver transplant. In certain cases, it may represent quite challenge to decide whether to perform extreme or complex resection, because sometimes you may have like tumor invading the IVC, tumor having 1 or 2 solid inmates. Professor Rasik told that if you are planning for transplantation, you have some mass in lung, you can surely resect it, see the pulmonary functions, wait for 1 month at least, and if there is no other sign of metastasis, go for liver transplantation or liver resection, whichever is feasible. And liver resection, whenever possible, liver resection is always the first choice. Liver transplantation is only when any liver transplantation for any cancer, liver transplantation is offered only when liver resection is not possible, for either tumor is too big or liver, we cannot resect the tumor by respecting enough volume. So continuing chemotherapy when the tumor remains unresectable is also contraindicated. The biggest hepatoblastoma response to induction therapy occurring during the first 2 cycles. Hence, it is better to shift the timing of the decision. Resection, transplantation after 2 cycles. I think this is what whenever we are preparing for the patient hepatoblastoma, we are always in sync with our oncology team, and we always plan any planned surgery always achieve better results, not just all these patient factor. So when the timing of the surgery, the planning, the multidisciplinary approach, there is also a bigger contribution for the better results. These are the comments now. Please run through it, take the screenshot. Whenever resection not possible, I'll go for, when there is no mix, I'll go for liver transplantation. Liver transplantation preparation remains, in cadaveric, mostly is not possible. They may not get liver. The liver cadaveric organ donation is less, so we go for living donor. Most of the time lateral lobe sufficient, but anyway, right lobe, left lobe, they follow the standard procedure. Donor is worked up. All standard procedure of the donor, when donor means healthy without any disease, voluntarily donating right or left or lateral, whatever. And then it is a complete cure because we remove the entire liver, the entire carcinogenic field is removed. So chances, if patient responded well to the chemotherapy, the chances of permanent cure, as Dr. Uchira says, can be 100%, but usually 5-year survival is more than 80% if prepared well and the timing of surgery is well. The challenges and certain facts. It is important to note that hepatoblastoma patients who present with extrahepatic or metastatic disease at diagnosis that fully clears with chemotherapy are still candidates for liver transplantation. Survival rates up to 80-85%. Some reports, have questioned the role of salvage transplantation, suggesting that it is connected with the inferior survival. But you will see, 80% I say primary transplantation, but 30-40% still is a big number. If my own thing is involved, I would like to take 30-40% chance. Now, in those 30-40% chance, we are comparing the primary transplantation versus the salvage transplantation. But if you compare the salvage transplantation with the no transplantation, it will be 40% versus 100% mortality. So I will still go for 40%. So among that 40%, maybe up to 30%, 33%, 30% people can have long-term cure. It still is a big number. So sometimes a percentage is just a number. I think we should act individually because a lot of emotions are involved, and if everything is possible, and as a team, we shouldn't deny any patient as long as we are confident we are doing with the right benefit for the patient. Now, extended indication cases of hepatoblastoma involving 3 or 4 sectors of the liver. Now, we did one last week. It was involving more than 5 segments initially, but after the chemotherapy cycles, 2 cycles, it sufficiently came down. But still, it was like segment 7, part of segment 6, 7, and mainly segment 5 and 8, and segment 4A or 4B, what do you call it? So we did extended right hepatectomy, including the MHV, and because patients lateral lobe was quite big, 8-month baby. A patient recovering well now in the ward, probably will be discharged within 2-3 days. I don't have images, sorry about it. So in rare instance, intrinsic complete resection of the tumor, main wall resection, the part of the diaphragm, stomach, mental, pancreas, whatever. Actually, as long as you're okay with that resection, if a patient can handle the surgery, and your expertise is there, you have done the thing, and you've got enough ICU backup, I think there is no contraindication for such surgery. In larger series of 27 patients, post-text 3 and 4, 1 extended liver resections with or without resection of adjacent structure. 5-year overall survival was 81%. 5-year event-free survival was 62%. So it was published in Annals of Surgery, 2017. I don't know how to pronounce the name of the author. You may ignore that. Several cases of successful multi-vessel transplantation for hepatoblastoma extending into the portomesenteric vessels have been described. Lietel published there, and they say that they don't have recurrence, so that is good. I mean, we should go for that. Multivisceral is a big task. At the moment, the biggest multivisceral center is in Miami. Thank you so much, and I will just run through a few slides, if you don't mind. So it's just a walk-in membrane. I was fortunate enough to study here in China Medical University Hospital. Nothing to do with China. It's in Taiwan. China Medical University Hospital. I was lucky to be a first Indian in entire Taiwan to do masters, what we call MCH here. This is our institute. I still remain the part of this institute, the big wonderful institute. Among top 500 medical institutions, it is 158th in the world, 2019 Shanghai ranking. This is my wonderful team. It was, or it is, and it will still remain. This is my professor, my mentor, who trained me with holding hands. Always used to say, no surgery is free for, no journey is free of dangers, and no surgery is free of risk and complication. But what really matters is choosing right path, right technique, at right time. That will virtually eliminate possible risk factor. We always meant that whenever you prepare for any surgery, you should have done that surgery inside your brain, well rehearse it. So ultimately, like whenever you have well rehearsed with this thing, probably you come across whatever danger might come in. And most of the surgeries we and Dr. Rasik Shah do together, we always have that virtual surgery already done in our brain. We draw it, we plan it, and whenever we do surgery, most of the time we don't find anything because we already worked on the danger where we're going to come. So thanks so much. And
thank you, Dr. Ashok Thorat. Our next speaker is the last speaker, Dr. Manika Boipai, who is a junior consultant in our department. And she will tell about radiation in role of radiation in hepatoblastoma. Manika.
mentioned that you were also part of last surgery, and because now you're part of surgery, we are a team.
Yeah.
Because the overlapping thing. There are only 2 things. Yeah, okay, yeah. Dr. Ashok here again. Dr. Manika is going to talk. Next budding liver surgeon, pediatric surgeon. So she was part of last surgery, and she helped a lot. In fact, she was the one who started the surgery, so she had a bigger role in last resection. And now she's going to talk about radiation therapy in hepatoblastoma. So please, Manika. Thank you.
Thank you, sir. I'm Dr. Manika. I'll be speaking on radiation therapy in hepatoblastoma. So chemotherapy and surgery stay the it is a mainstay of treatment in hepatoblastoma, and the role of radiation therapy in management of hepatoblastoma remains controversial. Hepatoblastoma is rendered radio-resistant because of very poor efficacy report. However, normal liver tolerance is not compatible with the curative doses required when large volumes are involved. Radiotherapy has seen to increase the probability of tumor shrinkage. Indications: it is indicated preoperatively and post-operatively as an aid to curative treatment of hepatoblastoma. When used preoperatively, it reduces the tumor burden and increases the probability of resection. It is also used in cases of unresectable tumors after initial chemotherapy. Its indication in cases of incomplete resection following surgery has been helpful. The role of radiotherapy also remains in palliative irradiation of entire liver or whole lung coverage in pulmonary metastasis. In preoperative radiation, 10 to 40 gray can be used in liver and about 7 to 20 gray in the lungs. So this is an article which studied the radiation therapy in the management of hepatoblastoma in children. This depicted various scenarios and the amount of radiotherapy which they used. So coming to the technique, radiotherapy was applied to patients with grossly or microscopically incomplete resection. It was started 4 to 6 weeks following surgery, so as not to interfere with hepatic regeneration. It was 5 daily sessions of 1.5 to 2 gray per fraction was induced. Cobalt-60 or high energy X-rays from linear accelerators were used. Tumor volume was delineated and covered by portals with a 1 to 2 centimeter margin. Extra margin of 0.5 to 2.5 centimeter was added in cephalocaudal direction to cover the diaphragmatic respiratory excursion. One of the patients received preoperative radiotherapy. She was a 10-year-old girl who presented with a massive right hepatoblastoma of the size 12 into 15 centimeter. A partial clinical response was observed. At laparotomy, extensive involvement of both lobes and hepatic conversions was noted. This precluded any further dissection. So she was started on a pilot study. A week of radiotherapy was given every month. 2 fractions of 3 gray radiotherapy was given along with 5 fluorouracil and cisplatin. After 4 cycles, complete resection was possible. During follow-up, patient was doing well and was asymptomatic. Radiotherapy was also given in 3 patients with massive tumor that progressed under chemotherapy. 30 gray of radiotherapy in large volumes were given, along with a boost of 15 gray in one of them. However, in this case, the results were not favorable and patients didn't survive. 4 of the unresectable primaries were controlled by, among the 4, 1 were controlled by radiotherapy. A combination of 24 gray was given to whole liver with concomitant 5 fluorouracil and cisplatin for a duration of 2 to 2.5 weeks. Radiotherapy, which was given post-operatively, was in the dosing of 25 to 45 gray. So the role of radiotherapy along with the chemotherapy only in selected inoperable children, and also when minimal residue is remaining below 2 centimeter. 3 patients had limited recurrence 2 months after the complete resection. These were managed by chemotherapy, and radiotherapy was targeted at small ultrasonically defined abnormalities. A total dose of 45 gray was delivered. 2 patients had pulmonary metastasis. One of them received 20 gray using cobalt-60, and second patient received 18 gray with 18 megavolts along with actinomycin. In the first trial, pulmonary metastasis was discovered after extended hepatectomy, and this progressed under the chemotherapy cover. Patient received radiotherapy, and after a 4-month free interval, multiple nodules were discovered again. Patient had a relapse in lung, so he had to undergo triple wedge resection through a double thoracotomy. In the second child, pulmonary metastases were discovered and they will deal with double thoracotomy. Radiation therapy in this case was administered as consolidation. But during follow-up, the treatment failure was noted and a phase 1 interleukin-2 trial was given. Now, the role of proton beam therapy for unresectable hepatoblastoma. Proton beam therapy is capable of excellent dose localization because of its sharp and narrow dose peak. Therefore, thereby preserving the hepatic parenchyma. Liver tumors with portal vein thrombosis can also be treated with using proton beam therapy. Here, a child with advanced hepatoblastoma was given this therapy who could not be managed with chemotherapy or surgery. The tumor thrombi was located within middle and right hepatic vein, and also it involved right portal vein. It was not considered. It was considered to be resistant to chemotherapy because there was an increase of AFP level after 2 cycles. So here, a total of 51.15 gray of radiotherapy was given in 11 fractions over 30 days, which was followed by 3 cycles of adjuvant chemotherapy. This the beam time was 4 hours per day, 120 days per year in 3 separate intervals of 9 to 10 weeks. After 16 years of this proton beam therapy, MRI showed no malignancy in the liver. However, the author did not recommend this for as a first line of treatment. He advised it to be useful for few patients with unresectable hepatoblastoma who are not suitable for complete resection or liver transplantation. Now, newer approaches have come, which like the one combining radiation therapy with angiographic embolization. This includes intra-arterial injection of yttrium-90 radioactive microspheres, also known as theraspheres. Radiation-induced liver disease, reactivation of viral hepatitis, and precipitation of underlying liver disease are the side effects. It can be seen in the form of deranged LFTs. To conclude, radiotherapy can be used with various doses, fraction, and volume schemes. It is almost always combined with chemotherapy. Radiotherapy, when used post-operatively, is valuable in children who have residual disease after an attempt of resection in the dosing of 25 to 45 gray in microscopic residuals and 30 to 45 gray in cases of gross residual disease. It has little role for palliation of symptoms in cases of inoperable tumor refractory to chemotherapy and in pulmonary metastasis. No clear guidelines have been stated till now because of limited evidence. Thank you.
Thank you, Dr. Manika. If there are any questions on the audience side, please, you can write in chat box or you can unmute yourself and ask. I think overall, we have covered everything what we needs to cover in hepatoblastoma. And I hope it has been recorded and we will put it online for people to come back and see it if required. So if there are no questions, I think we'll call it a day. Thank you all for attending this masterclass. We'll see you back third Wednesday of next month. And the topic, I think, is pediatric orthopedic surgery. Thank you. Thank you. Please have tea, coffee before you leave. मीटिंग एंड कर दे. रिकॉर्डिंग किया